first official SASI meeting and our inaugural meeting. And to my right is Mr. Eisner, and to my left is Dr. Tony Young. And in the crowd here we have notable physicians and industry. I am the president of SASI, and I welcome all of you to this inauguration meeting. SASI is an organization that has been in formation now for quite a while in various forms. Its purpose is in fact to bring together folks from different specialty groups that focus on minimally invasive spinal techniques, specifically surgical techniques that have been evolving over several decades actually. To my left is Dr. Anthony Young, who is a pioneer and has been and remains so. We are very happy to have him here, and as we go forward, there have been issues that makes this society a necessity. There are individuals, well-meaning physicians that have great training but have acquired their training through laborious traveling overseas, to specialist locations, and have acquired these skills without a usual standardization being in place. The purpose of SASI is to advance minimally invasive spine surgery to include not just traditional but also non-traditional trained physicians that have espoused the techniques, have learned, have become quite experts at what they do. We would like to be in a position to lead the accreditation, training, as well as ongoing introduction of peer-reviewed literature into minimally invasive spine surgery. There is no standard established right now. SASI can do that, and SASI will do that. You have committed members of this organization literally committing their entire career to making sure that the minimally invasive spinal surgical techniques that they have learned and believe in and seen help patients continue to grow. The techniques have evolved over time from the type of techniques that originally learned from even Dr. Tony Young, which is intradiscal, to more now where there's involvement of the extraforaminal approaches, to the compression of facets, to stabilization without fusion. All these techniques have evolved over the last near 2 decades. There is no one physician that knows all, but what we do know is industry is extremely interested in the skill sets of minimally invasive spinal surgery, and there are non-traditional surgeons that have these skill sets, and it is to the benefit of all that these skill sets are indeed conveyed in a meaningful platform that can be reproduced in a safe environment. I challenge everyone here to do their best to help grow this society. It does have a place. There is a gap that has to be filled. The society fills this gap. The folks that are involved are highly committed into making sure that it does it the right way. And I challenge everyone here to give the necessary time to make this happen. Thank you.
We're having a panel, so I kind of discussed with Walter, how are we going to do this to benefit the audience the most, and we're going to make it informal. Walter sort of is the moderator, and he is going to raise some questions, and hopefully I'll answer some of them, and you can interject at any time to question my position, because we all have a little different opinion. So maybe at the end of the session, we're going to come to some kind of consensus.
Thank you, Dr. Young. Like he said, we're going to keep it very informal. I'm curious as to, and by the way, I'm Walter Eisner. I'm a writer for Orthopedics This Week, and we've written extensively about, seems like I write a lot of stories about New Jersey in the last year. And so I'm curious, how many of you here are from New Jersey? Okay. New Jersey's been ground zero for what has become an extremely fragmented world of spine, because spine is an unsettled science. And one of the things I'm going to talk about is was a fascinating trial that took place last June in Newark, which we wrote extensively about, and I'll get into that a little bit. And I also want to introduce Eric Mühlbauer, who is the executive director of NAS. I think many of you had a chance to meet him this morning. Because this world of fragmented spine, unsettled science is giving ammunition to payers to deny coverage. It's giving ammunition to regulatory bodies to act in ways that some see as a restraint of trade. And so we're in this very disruptive time. In fact, Eric Topol, who is a physician from Harvard, has written a book called The Creative Destruction of Medicine. And we may not realize it, but we are perhaps in the most disruptive period in medical history ever. So you've got business issues that are at stake here. You've got scientific issues that are at stake here. You've got payer issues that are at stake here. And you guys are wandering into this fragmented, disruptive, boiling kettle of unsettled issues. And it's the great historian David McCullough, who some of you may be familiar with, he gave a speech a couple of years ago at the NAS meeting. No PowerPoint slides. He got up and talked, and for a half hour you could hear a pin drop. But McCullough says that there's nothing inevitable about history, that every moment that is the next moment is based on the actions and the character of the people that are in the time making those decisions. And as a journalist and a writer for our publication that's read primarily by orthopedic spine surgeons, those are the stories that our readers find most interesting, because that focuses all these big complex issues into stories about individuals, and that's why I'm here, to see if there's a good story here. Also, Michael Sheffield is here. He's a writer for the Memphis Journal, and I never write a story about anything happening in Memphis till I've gotten online to see what he had to write about it, because he's here and he always gets it right. So again, we're going to keep this very informal. We've written a number of stories about all this disruption, and there's been nobody more disruptive than Dr. Young over here in terms of the established surgical community and pushing forward the notion of minimally invasive surgery. The first time I met him, he did something remarkable, and I'll never forget it. And yeah, we were walking in Toronto at a NAS meeting. We had just met, and he tells me a story about a butcher. And I thought, wow, here's a surgeon talking about butchers, because that's usually not the kind of correlation you want to make. And he told me the story about the emperor's butcher who never had to sharpen his knife. And it was brilliant that he gave me a metaphor to understand this whole concept of minimally invasive surgery. And the story is that the emperor asked his butcher one day, "How come you never have to sharpen your knife?" And the butcher explained to the emperor that there are three kinds of butchers. And Dr. Young, you jump in and correct me if I get off the reservation here. But there are, not such good butchers, medium butchers, and really superstars. And I know in his training is what you want to create. You want to create superstars. You want to create the best professionals. So the emperor asked him about this not sharpening his knife, and he said, well, the bad butchers, they have to sharpen their knives every day because they're hitting bone, they're hitting tendon, they're dulling their blades. The medium ones, they have a better way of getting through, but he says the master knows how to get through the body without having to use that sharp blade to hit things. And that story always resonates with me as I think about minimally invasive surgery. The title of my part of the talk here is Spine on Trial, and that's in reference to this trial that took place in June. And for us, it really gave a specific example to this whole complex, disruptive cauldron of activity going on. The state of New Jersey wanted to take away the license of a physician, Dr. Kaul. For us, Dr. Kaul is not important. Sorry, Dr. Kaul. What's important was this turned into not who he was, but what he was. And the Attorney General said that physicians like him, with the level of training that they have, if they're performing certain procedures, they're deviating from the standards and the norms, and in fact are a danger to the public and should be defrocked. It's not the term they use, but it's the term I like. So there was a trial, and Dr. Kaul's attorney, named Shaw, I forget his first name for a second here, had on the witness stand Dr. Greg Przybylski, who's a neurosurgeon in New Jersey, and at the time was the past or the immediate past president of the North American Spine Society. The blood doesn't get bluer than that. And it was Dr. Przybylski's opinion that Dr. Kaul should lose his license, not because he's a bad doctor and that there were specific incidences where he had harmed patients, but because he was deviating from medical guidelines. Dr. Przybylski said that Dr. Kaul didn't have the training and the background to be able to competently perform fusion surgeries. His attorney, Charles Shaw, then politely and calmly dismantled, in my opinion, the charges that Dr. Przybylski was making as the expert witness for the Attorney General. Using Dr. Przybylski's own words, Shaw got him to admit that spine surgeons are not definitively guided to determine whether a fusion is even appropriate or not. And he further had him admit that they can't find the source of the pain much of the time. If there are no definitive guidelines, if you cannot determine exactly where the source of pain comes from, what are you deviating from? And we're not here to take sides. We're not here to say, what should be done. This was just our observation, and it was hard for me to fathom how you would make that charge. The fact that you, Dr. Przybylski said, the fact that you deviate from the guidelines isn't in and of itself a deviation. It's going to be very hard for Judge Solomon, I think, to reach a conclusion that deviation took place. He also went on to question Dr. Brzbilski about continuing education and credentialing. Dr. Brzbilski admitted that he and NAS train interventionalists, knowing full well they intend to perform the procedures. If, as an educator, you're training people to perform certain procedures, you shouldn't be surprised that then they indeed go out and perform them. After the trial, I had a conversation with Dr. Charles Branch, another former president of the North American Spine Society and a former editor of the Spine Journal. I have a lot of respect for Dr. Branch. He also studied journalism in college, so he's always able to give me a good storyline. He said the real question here, and then Dr. Young, I want to pull you into this piece of it here. Dr. Branch said that the real question here is, are there interventional fusion techniques that are effective? If so, what are they, and for which indications, and are the interventional pain physicians the appropriate resource to provide that care? There is not a clear answer to any of those questions, which fuels bigger turf and economic wrangling that's coming to a head in New Jersey. Hence, said Dr. Branch, in New Jersey, because credentialing is local, as it is everywhere, a regional or community effort to establish a credible standard is now polluted with politics, power, economic restraint of trade, and on we go. So you have probably trained more interventional pain physicians to do surgical procedures. I don't even want to call them surgical procedures, to do the procedures that you teach. And the question that Dr. Branch put up, are there interventional fusion techniques that are effective, and for which indications, and are those physicians the appropriate resource to provide that care? How do you think about, how would you talk to Dr. Branch about his statement with that?
Try to keep a simple answer is difficult, but the simple answer is yes. It's evolving to the point where we can do a fusion percutaneously under local anesthesia with the same concepts of fusion that the open surgeons use. Now that is going way beyond what the fusion surgeons are willing to accept, but it can be done, it has been done, and I have done it. Okay, I have done it under local anesthesia and sent the patient home. So the skill set has to be practiced, but fusion is one area that is more than just a technical procedure. We have to know the biology of the spine. We have to know the material used, such as bone grafting. We've shown historically that putting bone even from the iliac crest into this space does not cause a fusion. And so that's where we put in a spacer and we put in screws and we keep adding hardware. So we have to kind of draw the line, because knowing how to do it technically is not doing a fusion. If you're doing a fusion, you have to know the biology, the materials that you use, whether it can be dangerous. And recently, the concept of is BMP safe? And Eugene Carrigy has said, hey, industry had made it was safe, but they're hiding these facts. But in reality, these are small deviations that was not hidden, but it was not magnified because, of course, the company wanted to sell the product. And so I will give my own personal opinion, that's a personal opinion, that I draw the line for appropriate training to spine surgeons who really have to spend a whole year, and now even more than a year, 2 years of fellowship to learn how to do this well. But I can do it technically, but do I understand, you know, the osteoconductivity and the different avenues to gain a fusion? Every thing we try to do when we do a fusion is to get the bone to fuse. Everything else is just supplement. And I happened to start my residency in 1971, where it was considered instability if you had to remove a disc, so you fused. Mayo Clinic did that. But we fused without use of hardware, and it was hard work. But when it became easier by the use of hardware, it became an economic issue because the surgeons got paid for every little screw they put in. And so everybody wanted to jump in to make the most money with the least effort. And that's where kind of it's gone awry. And even then, the surgeons are doing all they can to preserve fusion. But fusion is not a technique. It is it's a science that is still evolving, and it is so complex that no interventionist who knows how to technically put in a screw or put in bone is going to be qualified to do it. So I draw the line there that to set the standard, you have to then go through proper training to obtain a fusion. But having said that, if we as interventionists are successful in treating the source of pain, we're going to eliminate 3/4 of the fusions to only severe deformity and instability, true instability, not mild instability. So the future is going to do what insurance companies, payers all want. They want to eliminate the very expensive fusion procedures that, in the term of qualities, is from $30,000 from Dr. Dennis Crandall to $50,000 to $100,000 according to Dr. Polly. That's still too expensive, and that's where the interventionists come in. We're going to be disruptive to the fusion surgeons, but we're not going to be really qualified to do fusion unless we're trained as fusion surgeons.
Which is one of the reasons you've established the Young Endoscopic Center at the University of New Mexico.
I decided that, I have 5 stents in me and I could be gone tomorrow. So I had to make sure that someone's going to carry on my work. And I have 2 professors from the University of New Mexico that decided to come, Dr. Fred Harrington, neurosurgeon, and Dr. Evan Rivers, who's non-surgeon, PM&R. They're both training to do this procedure, but they're doing it in an institution with a boss who is envisioning that this should be a multidisciplinary approach, and we should work together to see who is best qualified to do which part of the procedures to treat our patients in pain. So they came just to monitor what's going on, because I think University of New Mexico hopefully will be the future in establishing the standards of what type of training is needed. They have no economic incentive. They're professors, they're teachers. So I invited them to come, and I'm glad that they did come, because I like to hear from their perspective, because they have begun training with me for the last 3 months, and they actually scrub in.
At some point, we may have a question for you, or the audience may have some questions for you. If anybody has a question as we're going along, just raise your hand. We'll be glad to entertain it. Eric, if I might ask you, this notion of the establishment of standards, credentialing, a new society cropping up. You're not a physician. You're an attorney. Sorry, I don't mean to get everybody mad at you just by saying that. But you've been running the North American, as executive director of the North American Spine Society for 10 years?
19 years.
19 years. Yeah. How has NAS looked at folding in this branch of spine care into its membership, and how and what efforts are you looking at now on the credentialing side that would bridge this gap between surgeons and interventionalists? And is that even the right way to frame the question?
It's an interesting dilemma, because the field is very fragmented. There's interventional radiologists, anesthesiologists doing pain management, physiatrists, surgeons. There's a lot of people getting involved in this kind of treatment. There's societies all over the place. There's the SMISS, there's the International SMISS, there's International Spine Intervention Society. We have a minimally invasive spine surgery section within the society. So the trick for us is, you know, we're a third generation medical society. The first generation is American Medical Association, American College of Surgeons, big, broad. And then about 100 years ago, you had specialization. American Academy of Orthopedic Surgeons, neurosurgeons, radiology, anesthesiology, they all popped up. So it was all about, you know, what your board certification was. We don't care what your certification is in, as long as you do 50% of your time in spine. Our job is to develop well-rounded spine doctors, not just surgeons. So our strategic strength is in multi-specialty education. So we think that the interventional market, for lack of a better way to put it, is a potential growth area for NASS in the next 5 to 10 years. And we want to bring these experts into the society so that we have a well-rounded approach to teach, you know, our members the ins and outs of all these different procedures. So, you know, if you're an orthopedic surgeon and you're learning from just orthopedic surgeons, everything looks the same. We have a lot of accountability in our education because we've got physical medicine specialists, neurosurgeons, orthopedic surgeons, anesthesiologists, some nurse practitioners, holding each other accountable for what you're trying to teach. So, you know, Dr. Kaul, like you mentioned, he's been to some courses at NASS. And we've had this discussion, should we have prerequisites? Should we have certain level of, you've got to meet this standard in order to take a class? Well, if we're not going to educate them, who is? So we have a duty to try to educate the field. You know, and the problem with some organizations is that they make decisions based on what's best for the organization as a business entity. We pretty much stay focused on what's in it for the member. And as long as I'm at NASS, that's going to be our focus. So I'm here partly because Tony, I talked to him on the phone a couple weeks ago. He encouraged me to come, and Walter did too. I appreciate what the society is thinking about doing in terms of putting together standards, because that is critical. We've been talking, my membership director is here, we've been talking about whether or not we should develop credentialing, like a board certification in spine. There is a board certification in California, and there's the American Board of Spine Surgery, but it's a very limited group. They're not ABMS certified. So it's not very well received in the field. All neurosurgeons have a lot of spine in their training, so they don't think that they need to have a certificate of added qualification in spine. In the orthopedic surgery field, there is a hand surgery CAQ, it's called. So we're going to explore whether or not we should do that. But then we're just serving a fragment of our members, just the orthopedic surgeons. So it's a dilemma. And do we promote credentialing for spine medicine, spine interventions, spine surgery, or do we develop a whole new term, a spinologist, like a cardiologist? So this is stuff that our board's going to be dealing with in February. We have a strategic planning session, and this is on the radar. And that's a long answer to a short question.
No,
but,
that's very...
But these are complicated issues, so it's... and you're right, there's a lot of turbulence. There's a lot of white water. So, and it's important to stay focused on what you can do well. And if this society is going to be good at developing standards that raise the ability to care for patients, then it's got a place in the world.
Thanks, Eric. So you have the executive director of NASS here. You got any questions for him?
Well, I am quite tickled to hear what you have to say, and there's a lot of credibility to everything you've said. I'll just go back even 25 years ago to when even inside NAS itself, there was a huge tough battle, I guess more like 35 years ago, between the neurosurgeons and the orthopedics regards to spine, you will recall. And it got resolved. It got resolved over a period of 5 to 10 years. And I would hope that we can speed up such a resolution. It doesn't have to take that long in this context. I totally agree with some form of standardization, and I would challenge everyone here to understand that the skill sets that we're talking about is acquired currently through multiple layers of training that is not yet available at one location. And you have to be quite dexterous to really understand and use the skill sets. On top of that, I totally agree with Dr. Young that it's not just getting the skill sets that's important. It is also appreciating the underlying clinical presentations, the nuances, the non-science part of science of medicine, and applying that to specific clinical situations. And that comes with multiplicity of exposure and trial and error that we think that being able to convey in a more standardized fashion, we can accelerate the training, the non-technical training, and that's the point of the accreditation that we feel will fill the gap between the interventionist and being a true spinologist, if you want to call it that way. So I think you're on the right direction. I think SASI is there with you, and you should take it as an opportunity to incorporate this into your thinking.
There's other groups that doing this on your own, while laudable, is just, it does fragment the field. And so you've got to do it the right way, otherwise it won't be accepted. You got to go through the ABMS. You've got to have the buy-in of all these other groups. Otherwise, they're probably going to have, at least at a very minimum, passive resistance to what you're trying to accomplish. So my suggestion would be to try to work with and within some of those groups, if possible, because this, like I said, the American Board of Spine Surgery, I'm not sure how many people they've certified. It might be 1,000, but it's not recognized anywhere. There's no reimbursement that you get extra because you're board certified by this group that a bunch of docs just decided we're going to put together a certification program. So it's got to be done the right way, and you only have one shot to do it right. So that's the only advice I can give you. And NAS can help too if you want some help, because this is an area that we think is important, because ultimately these doctors are all going to be treating patients, and our job is to enhance spine care. It's not to enhance it for orthopedic surgeons, for neurosurgeons, for physiatrists. It's for the patient.
Yes, well, I appreciate it. A number of the members are already members of NAS, ICs, and the various organizations, just so we are correct on the record. So that's already established, yet there remains a gap. So there is a place for SASI in all of these configurations, and we certainly hope the societies will work with it together.
Can I just ask a question about what you said before? You were talking about that there's this education and understanding about the biology of fusion. And so just for me to get this clear, so you're saying that physicians that come from backgrounds of interventional pain and interventional radiology do not have that understanding?
That's correct. It's much more complicated than a procedure for a mechanic to do. Like, you don't want to go to the corner gas station and have a mechanic fix your BMW. It's too complex.
Right.
They have just as much chance to screw it up as, helping.
Yeah.
So I don't think I'm if I'm a pilot, I can't fly the space shuttle, okay? And I'm an orthopedic surgeon, that doesn't mean I know how to do fusions. And what I'm saying is, we have surgeons that are spending 1 and 2 years of fellowship to learn how to do fusions, which is their major procedure. And so to have someone from the outside come and say, I can do a fusion, I think that's probably bridging too much of a gap. And I hope in my talk, I will support a lot of things that interventionalists do that will fill the gap, and I think they'll do it better than surgeons. So, but to do that, you have to work together.
Right.
So maybe that line is going to shift, but right now, I'm going to take a stance and I'll explain why, if I need to, why I think I draw the line with fusion, because I supported, for instance, Steve Kutchlich bag for spinology, put in a bag. I tried 6 of those, none of them fused. Okay, but the patient got better, and it looked like they had a fusion. But I know it didn't fuse because I used BMP, and it went in the foramen. I took out the BMP, and the bag broke, and all the material came out like sand. So if you're using sand to put between bricks, it works as long as it stays in place. But it's not a fusion. So it's a matter of calling a fusion. Just like an interventionalist say, I'm a MIS surgeon, is it deceptive advertising, say you're a surgeon? If you say I'm an interventionalist that will help you stabilize your spine, that's different. Okay? So we're talking about somatics, and we have to work out these type of somatics. You know, everything is economically motivated. You know, Medicare pays for extended care, and there are certified centers, and there are people who just open a room in their house and advertise that we're certified by Medicare to, you know, take care of elderly people. But really, they just open a room in their house. But they're gonna get paid, hopefully, if they were billing Medicare for that service. So I think it comes under, maybe the lawyers can answer that, when does it become false advertising? So I have a problem, and I'll explain why, with labeling yourself as something that your training does not certify you to do. I don't have a problem of you doing it and doing it well, as long as you tell the patient, I know how to do this procedure. I'm not trained as a spine surgeon to fusion because it's very complex. Yeah, Gabe.
We're talking about what the purpose of SASI is. And as Sol Kempson said, that one of the purposes is to standardize, actually what I think he meant to say is standardize a training system so that we can learn how to do these procedures. I have trouble when it comes to, we have to standardize medicine. I'm sure everybody does, because we're the type of physicians that if it wasn't for us, this procedure never would have existed, especially you, Tony. If we standardize, you want to develop the technique that you've arrived at today. Now, that's one major important aspect of SASI. I'm going to create a little bit of a wave here, and I appreciate what you're saying about sticking together, which we plan on sticking together with all the societies. But it's coming out right here in this meeting that interventionalists, we don't have too many friends. Tony Young, you know, he's helped us out, and I've learned a lot from Tony Young. But there's certain things that Tony Young does not want us to do. There's a lot of things that NASS doesn't want us to do. You have the American Academy of Pain Medicine, or interventional pain. They don't care about us because surgeons send them work. They don't want to get the surgeons upset. So we need to create a society of minimally invasive spine surgeons that are together, and we form an army to protect ourselves from people who think that we shouldn't be doing certain things. That's one of the purposes of this society. I just want to bring that point out.
Well, Gabe, let me respond. You're very good. You understand what you can do, but you're one of the few non-surgeons that challenged me when I was giving a lecture, and I say, wait a minute. You know, I think I said something like, you're not a surgeon. I'm teaching the course, and you're wanting me to do what you're doing. It is not the right standard. I did some research on SASI and what you think is the standard. That is to do a procedure with local anesthesia, discharge in 12 hours, and have less blood loss. That's like saying, don't make the patient worse, and you got a standard. I mean, that's too simple a standard.
That's when you wanted to call the cops on me, right?
Well, no, I
Throw
said,
me out?
I can set that standard. I said, come to me, and I'll do a sham procedure on you, and I will hypnotize you to get you better. You know, the standard has to be higher than that. So if I had to comment on your standard, I think that's too simple a standard. It's like I have an MD license, so I can do anything I want. We're way beyond that.
With the proper training,
Well,
we're
with
in
the
America,
proper
Tony.
training-
Tony, we're in America. With the proper training, this is a land of freedom. With the proper training, you should be able to do whatever you want. If the person's not capable of doing it, this is where the societies step in and say, you're not capable of doing
Well,
this.
let me give you an example. I travel and teach in China. They have traditionalists and they have Western trained. The people in China says, if someone tells me what I have, I'm going to go to a Western trained doctor. If they don't, I'm going to go to both because I want to, try both. And they get along because there's no competition economically. Everybody's paid $20,000 a year by the government. And the government is saying, we're spending all this money for these mega hospitals. We're not doing any good, so they're welcoming private practice. So if you're going to do it and do it well, then I think you may have to guarantee your results, just like going to a car dealer and it's a lemon, they get the money back. Are you willing to do that? I don't think we can do that for everybody at this time because we still don't understand the outcome. If you don't make a patient worse, does that mean you get paid? Do you have to get them better? Do you have to get a fusion to get paid? We're working through all that right now. So what I'm saying is, I hope the standard is high enough that it will allow you to attain that. You make it low enough, everybody qualifies.
No, that's not our goal. Our goal
I know,
is
but
to be
I
very
read
respected.
your standard. It's too low.
You don't know what my standard is, Tony.
Let's be clear that SASI has not yet established a standard. What we have established is the definition, what SASI established as a rule of 5, the definition of minimally invasive spinal surgery as we see it, which encompasses fluoroscopic technique. You're not going to argue with that, are you?
No, but
Okay. Hold it. It also establishes the extent of dissection. Are you going to argue that minimally invasive is encompassing of that?
Well,
no, just say yes or no.
say that again.
I want to get to a conclusion.
Yeah,
guys.
I will
just
tell
want
you.
okay,
If
just
I'm
say
not
yes.
sure, I'll say no. But
Okay,
let me
that's fine. Are you going to argue with the fact that minimally invasive encompasses minimal dissection?
Yes.
Correct. Are you going to agree or disagree with the degree of bleeding that one expects from minimally invasive? Yes or no?
Yes.
Are you going to agree or disagree with the fact that it is important to be able to discharge a patient from minimally invasive within a certain period of time rather than in a hospital? Because I know where you practice. Yes or no?
Yeah. The answer
Yes or no?
is yes.
Thank you. So those are the various things that we agree on at the minimum starting point. We haven't established a comprehensive approach. We don't care whether it's fusion. We don't care whether it's motion preservation at this point. We're simply trying to get consensus on what is obvious. Yet you go into a courtroom and becomes a debate. We shouldn't be debating what is obvious. That's all I'm saying.
Okay.
Thank you.
You can do a sham procedure and meet your criteria. You can do nothing but meet the criteria. I mean, that's not, and then you want to charge for it. So I'm going to challenge you. If you use that criteria, it's so low that it says, hey, if you hang up a sign and say, I want to sell snake oil, and it's actually water or virgin olive oil, you haven't harmed anybody, but are you doing them any good? I'm saying you got to change your standards to make me more specific. And I have a chance to show what I mean because I've lived through it.
No, we're evolving. We haven't established the full set of standards on every procedure on how to yet.
Well, then
we're at the conceptual level and having an agreement. And at the conceptual level, we want to make sure this agreement crosses all specialty lines, neurosurgery, orthopedic, and all the various specialties that NAS embraces.
I think we can debate that from the audience, but if you talk to surgeons, they're going to say, you know, why do we get extra training when we can do anything and meet the
This
criteria?
gets stupid, and it's, like Eric said, you got one shot. Dr. Kaul, you wanted to jump in here.
Actually, to Eric, and his comments about NAS and the other societies. One of the main reasons, one of the reasons for SASI coming into existence was to also provide a legal platform that its doctors and its members could reasonably rely upon if they had to enter courtroom in the United States or a medical board. And I think one of the issues that most of us have experienced is lack of support in professional societies when these legal issues present themselves. Sorry. And so while I appreciate your comments about the collaboration and the coming together and finding a common ground clinically, which I think is a good thing, I just wonder how that, or if it would, translate into any legal benefits to the members of SASI, because that's one of the threads that we're going to be communicating strongly, is that if you're a doctor, you're a member of SASI, and you run into these issues, we will be there for you and not leave you hanging dry. So, you know, that faces all of us in the medical profession. And, I mean, and personally, I feel that the medical profession, if no doctors testified as experts against other doctors, very few of us would be in courtrooms. But that's not the case. And so with SASI, what we're trying to do at the very least is to provide a panel of experts that will go to bat for its members.
Well, in response, you know, what NAS has done relative to expert witness testimony is put together ethics guidelines. So, you know, one of the reasons that Greg Shabilsky was so straightforward in his responses is because what we do is we police our own and make sure that expert witness testimony is fair testimony. It doesn't become advocate testimony. And so there's a big difference. So you have to be very careful when you put together an organization with that as one of the goals, because you've got to make sure that any of your experts have a very solid basis by which they form their opinions. And spine is very well undefined. We know that. Fusions, you know, there's not enough evidence to support anybody saying that it's the definitive treatment for this, that, or the other thing. So we have to admit where we lack evidence. So I would just caution that, you know, take a look at our website. We're happy to share our ethics program. If you want to have expert witness testimony as a key ingredient in SASI, more power to you. But make sure you do it the right way so that you don't end up getting criticized later. Again, you got one shot to do this right. And we're here as a resource. I'm not interested in, you know, NAS taking over this, that, or the other thing. We're a resource. We're here to facilitate good spine care. And if you're an expert in doing things one way, Tony's an expert in doing it another way. We've got a neurosurgeon, physiatrist, they are experts in doing things another way. Our job is to bring all the best practices forward and try to teach whoever comes to our meeting the best way to treat patients. So.
For the technical folks, we're ready to have Dr. Young pull up his PowerPoint slides and go into his presentation. One thing that really struck me as why is there no support? In one of my notes I had, Why do they hate us? And I've spoken to a number of surgeons about what really is behind their problem with you. And I kind of see three things. One is, being a political scientist, I always want to follow the money. And clearly, when you're setting up ambulatory surgical centers and you're taking business away, the restraint of trade, that's clearly there. Secondly, there are some surgeons who, honest to God, believe that should something go wrong when you're doing procedures and an open procedure is required, that you may not have the training for that, and you should have, for lack of a better word, a lifeguard with you, or in relation to help out with that. So there's patient safety. But I personally believe it's a third thing that Dr. Young just sort of touched on here. And I heard it from a surgeon who said, how come they get to call themselves surgeons when I went through all this training? And it got me thinking, having had some experience in politics and what's called economic rent in the regulatory and the public affairs, why is it important to you to call yourself surgeons? You have a specialty that potentially, for payers, for the way the science is going, will gravitate towards you. Why pick a fight over terminology when you could go in a different direction? So I just throw that out as an observation. Steve?
You know, Tony alludes to the fact that it's a matter of semantics. It's just more of being practical and unemotional. You know, I've been on the sidelines for a long time as a non-surgeon doing surgery. When I talk to my patients and educate them, informed consent, I clearly let them know that I have not formally trained in surgery, and I would not call myself a classically trained surgeon. However, I am very well trained, done thousands of cases in minimally invasive spine surgery. So I am not a surgeon, but I do surgery. And the fact that I do surgery minimally invasively really doesn't make me a classically trained surgeon, but the fact is I'm a physician who's cross disciplines for the benefit of his patients. There's no formal training. That's what we're all here for, to formalize it and to standardize it. But I am not a surgeon. And when the surgeons get pissed off as far as territory, ego, economics, formality, there's really no room for that in medicine, but the world we live in dictates that they become problematic for any number of reasons. When you get back to why they're problematic, none of it has to do with patient care. It has to do with how things are structured in the politics and economics of medicine, like you talk about. It doesn't make it right. And so as we move forward, this headbutting between surgeons and non-surgeons, I have no problem saying I'm not a surgeon. I am not a surgeon, but I do surgery. And the surgery I do, I'm very well equipped to do, which most of the classically trained surgeons are not, because they have no formal training, and we're defining the standards as we move along. But there's a tremendous amount of time we spend bogged down with this stuff that serves no one. And the way is, how do we navigate through that field effectively? Because better physicians grow in their practice. People are interested in taking care of patients, learn new information, techniques, knowledge, and surgeries to help their patients. That's why we're physicians. There's a tremendous distraction with what goes on between organizations and surgeons, non-surgeons. We've got nurses now doing interventional pain management, Medicare approved. No, they have no formal training. They are practicing medicine. But yet we have a problem with other subspecialties crossing disciplines for all the wrong reasons. And it creates a barrier. And in Europe and in the Far East, it's not as bad because they don't have the same economic systems and the same politics going on. So you're not under a microscope all the time.
Thank you. Okay, we've got about a half hour left in this segment, so I think we better get to your slides. Are we ready to pull those up?
Sure. Everything is economically motivated. That's why escape communist China. And communist China has decided that capitalism is good, and so they have a dual system. We may have to have a dual system. I was told that this is going to be a turf war. So Walter suggested I talk about the art and science of spine care and who owns the right, especially in this new era of endoscopic lumbar surgery that is beneficial to patients. So we all agree that what we do is beneficial to patients. This is my disclosure because I'm a NAS member, and I'm very opinionated. I'm very biased because I've lived through what I'm going to show you. I look down on the people who are on the NATO team, which we no action, talk only. But this is all action. This is what I've actually lived through and done. Okay, so I invest in everything I think is going to make money, and that's good for my patient, but my patient comes first. So why is this panel important for the future of spine care? I think we went through a lot of that already. But in my opinion, Eric, large multi-specialty spine organization and societies like NAS currently have little to offer medical practitioners like me who have reasons to contribute, but because of the politics of the program chair and the vice presidents, we're down to core curriculum, and you lost all the innovative surgeons and non-surgeons because what you're doing is going back to medical school and telling them core curriculum in your programs. Sounds good, but it gives you nothing to take away home when you leave the meeting. So the problem is that we have people with diverse background training who wants to do an area that is very good and it bridges the gap between traditional surgery and interventional pain management. That's the result of the so-called turf wars. It really shouldn't be a war because we should be there for our patients, like you said, okay? But we all not only want recognition, but we want recognition and payment from insurance companies to do what we do, okay? And so, well, we'll be able to find some common ground. My experience, having trained hundreds of surgeons and non-surgeons, is that this is definitely not a see one, do one, teach one procedure. Some of you, like Steve Levine, may catch on right away, but Steve Levine has been coming to me for 15 years. He's finally coming out of the closet and decided to take a chance to back up interventionists. But Steve knows there are surgical pitfalls that require careful practice, careful mentorship, and evolution of experience. You cannot just learn how to do a technique and do it well technically and be able to accomplish what you want to accomplish. So you have to start with the recognition of what's normal and what's not normal, and it's based on a gradual buildup of your surgical skills having used this long learning curve. You cannot be an interventionist and be a fusion expert, and you cannot be a surgeon and become an interventionist. You have to work with proper training through the middle. So how many of you know what's normal and what's normal? Is this normal? This is the same view of the framing. Is this normal? Is this normal? Is this normal, normal, normal? Well, everything here is normal, okay? Everything down here is abnormal. This is an autonomic nerve. This is a herniated disc rupturing through the annulus. This is a focal nerve that's in the foramen that may not even be connected to the main nerve, and here is a focal nerve, a branch of the main exiting nerve. Are you good enough to recognize that and not cut it or to avoid it? Okay, you can't do that without having some experience and knowing when to stay out of trouble. If you come to Arizona, you see a rattlesnake, and you say, oh, that's a cute little snake, I'm going to pet it, right? But if you're smart, you say, this is not somebody you want to touch. So you have to learn that. However, having said that, being a surgeon who had trained, not fellowship trained, but I train fellows now, in that the turf wars and scope of practice have been around for decades. I lived through optometrists versus ophthalmologists, chiropractors versus orthopedic surgeons, podiatrists versus orthopedic surgeons, physiatrists versus physicians, cardiologists versus heart surgeons and thoracic surgeons, even neurosurgeons who decided that they were going to do fusion in the 1980s. They were terrible until they learned how to do it. Now they work together as a team. So it does evolve. The current focus, the current standard is more on proper surgeon training or interventionalist training, like you said, than what you call yourself. But when you're here in the United States, you have, truth in advertising is that you have to let the patient know that you are not a surgeon and not mislead them, because in informed consent, you can get sued just for making them think you're a surgeon. So I think it's best done in an environment with no financial incentives at stake, and that is going back to our training program. That's why I decided to establish an endoscopic spine center at University of New Mexico, where they don't have any one person who has economic gain to be able to develop what is good. So keep that in mind. That's why I invited Dr. Harrington and Dr. Rivers, a surgeon and non-surgeon, whose boss is a surgeon who's a brain surgeon, that supports this concept. Okay? So surgical spine treatment is validated in the peer-reviewed literature. We know that already. We believe that the sports study has shown that even comparing with non-surgical practice, it's better, but the surgeon factor is important. The problem here now is that when you have painful progression in an aging spine that goes to stenosis, spondylolisthesis, it's currently treated by decompression and fusion, but now we're getting resistance from the payers because it has gotten too expensive because of the implants and failed back surgery syndrome. A very good surgeon, my own team, Dr. Chris Young, my son, and the people, we get over 90% success rate even if we do a fusion. But we also get all the failed fusion from the average surgeons, which I call Bubba surgeons. And when you average it all down, it becomes 70% effective. Those who get the fusion not effective and maybe is worse off is what fuels the people coming to us for alternatives. Now, I'm going to put a plug for IITS.org. This is a organization where I'm the executive director. I took over when Kaul was not available, and I was president of IITS. It is called formerly IITS, and has a 26-year history of a multidisciplinary society formed at that time to promote Kaul pain, the only level 1 validated MIS procedure. And now NAS is saying we need to go back to evidence-based medicine. If that's the case, support us what we do as MIS surgeon, because we represent an approach that is validated by level 1 randomized study. But as we go forward, it's like, say, we have to prove every little thing we do. None of the surgical procedures have had that. It's like you don't need to know you need a parachute when you jump out of an airplane. It's just intuitive. And so intuitive is to come in through an approach like Dr. Kamsen said, no bleeding, outpatient, and so forth. But to me, that's way too simple. You have to refine it better. If you use that as a standard, you're going to laugh. So as the executive director, I was also given the opportunity to be an editor of a special edition of a peer-reviewed journal through ISASS. I'm going to be the editor to screen papers. I'm going to invite you, Saul, and you, Steve, to submit papers to go through this peer review process that is exactly as vigorous as spine. So we're using their format, okay? So don't say we're going to try to hold you back. I want to see some papers from you, and it's review blinded. Nobody knows who it is, but it'll be reviewed by the same standards as we do for spine, okay? So only I will know who you are, but it's going to go through a peer review of 3 reviewers, and you need 2 out of 3 to say accept, and you'll get it in. So that's my challenge to you when you say you're being left out. Okay. So, however, the surgeons are also wrong when they say minimally invasive spine surgery is the use of tubular retractors and smaller incisions, but using the same approach. Well, they're not MIS surgeons, okay? They're just surgeons that use a smaller incision, and we're competing by millimeters. It means nothing. You can have a big, long incision and do the right surgery, and the skin heals side to side, right? Just don't do damage to normal tissue, like you said. So the problem is that the surgeon factor debate is currently being avoided because there are good interventionists, there are good surgeons, there are bad interventionists and bad surgeons. My fear is that I don't want to train a bunch of assassins out there who says, I was trained by Tony Young to do MIS, and I'm not sure if you have the qualifications. So I'm a little bit worried about guys like Jasper who says, hey, you know, do it my way after listening to me one time. I said, wait a minute. Learn and then have some credibility like Steve Levine, and I'll say, yes, I understand. Even Sol Campson, 2004, he visited me. I'll show you a case that he watched. I have his picture. And so from there, he went on, but he's never come back since then. But I like to see how your skill set is. So I'm going to tell you, this is my personal opinion based on my experience training surgeons and non-surgeons for over 20 years. And I have a lot of arrows in my back for doing that. Okay? The turf battle is not isolated to surgeons versus non-surgeons, because I have personal experience and knowledge that experts who want to stop you are going to provide vogue and mercenary opinions based on their personal agenda and who pays them. And I don't mind letting you know that it's a prominent guy who used to be on the NAS program from a prestigious neurologic institute. We are enemies because I've taken patients away from him, including relatives of his nurses who decided to come to me, and I was able to get them better without what this surgeon wanted. So while prominent surgeons acknowledge that the standards of care is evolving, these surgeons are also very influential in securing podium time at major spine meetings to get their papers accepted in peer-reviewed journals. How are we going to prevent medical censorship, Eric? And how are you going to have a program that will satisfy what the purpose of NAS should be? It is not to provide core curriculum for surgeons already who have accomplished in practice, who have nothing to learn by the type of programs that are being produced as if we were medical students or residents. So, but I acknowledge there is a gap in training by surgeons versus non-surgeons and non-surgeons versus surgeons. We come from a different way of looking at things. We have to be able to work together. So while all surgical procedures can be potentially converted to percutaneous, it doesn't mean it's all effective. But I'm talking about there are all kinds. I'm talking about the foraminal approach. And here you have all these approaches that can be minimally invasive. Walter.
We had a question here.
Okay, yeah, let's open up to questions.
Get to that one.
Sure.
Just a surgeon thing. Would you say that a classically trained neurosurgeon, fellowship in spine, or a classically trained orthopedic surgeon with a fellowship in spine has any advantage in coming in initially versus another interventional physician in performing endoscopic spine surgery? What advantage does that training give them in the techniques that we utilize to decompress the spine?
No advantage.
That's all I want to ask.
Okay? In fact, I think I appeal more to you than to them. They look at me as the outside taking away their business. But there are some things that they do that they know more than we do,
Sure.
like fusions. I was the original guy to do fusions for barrels, but I did all my fusions without hardware. It was hard work. It wasn't until we got paid for putting hardware that the neurosurgeons decided to take that up, and they were terrible in the beginning. Now they're just as good. Yes, Richard.
Tony, could I just ask you to specifically state to me what it is about the training in fusions that gives these surgeons the right and the ability to do fusions and not, say, for example, an interventional physician who's gone and taken a multitude of courses on the biology of fusion?
Because fusion is not simply doing a technical procedure. It's a combination of doing a procedure well, not causing damage, knowing the biology of fusion, knowing the type of material to use, knowing what not to use, knowing the risk of using biomaterials that is out there. So in the end, if you can get a fusion without having to put in hardware, put a bug in there, cause an infection, and then clean it out, you'll get a fusion very rapidly. It'll collapse. But that's not the way to do it. So it's too complex. It's complex enough that spine surgeons take a whole year to learn how to do it well, and some of them are taking 2 years. If they're going to go into MIS surgeon, Dr. Harrington has extensive experience, but he sees that using a different approach is going to be a good.
But let me ask you,
can't come in from the other side and let's say be an astronaut.
right. But let me ask you why they are taking so long to learn something that, to be honest with you, I mean, you know, there are some, you know, biological principles and elements of understanding, but it doesn't, I mean, taking 2 pieces of bone and using biologics and using bone augmenters and placing those into that particular part, I don't quite understand what it is that...
That's why it is dangerous for non-surgeons to learn that, because it's a lot more complex. What is so difficult about flying an airplane? They're designed so that you just let everything go, and you have an 8-to-1 glide ratio, you're going to land safely. But in the case of an emergency, you can't handle that. And so I think it's a lot more complex than you actually realize. Gabe.
I have to defend myself a little bit here, Tony. You've publicly announced on the video that people like me you're afraid of that are dangerous. Well, that's what he insinuated.
Yeah, I didn't say that. I said I have some concerns about people with strong feelings before they know the background.
Okay.
And I
just want to make an announcement. I just want to make an announcement,
myself.
Tony, that you're not the only minimally invasive spine surgeon that I've learned from. I've learned from all over the world. I've gone to Korea, France, Germany, Holland, Austria, Switzerland, California, Arizona, Florida. I've been all over the world to see the best doctors that I would put you in that position as far as one of the best doctors, surgeons that I've seen. And I've taken all of that into consideration. And I take it as a compliment that after I told you how you should do certain things and we argued, that I've seen some of your videos and you've taken my recommendation. That's very nice. Thank you very much.
Well, I think if it makes you feel good, yes, it was what you had in mind, but it wasn't your recommendation that allowed me to evolve that. It was way before then. And so that is one of the points maybe we can debate.
Well, quick question.
Yeah.
But you overstated some things, and since this is going on record, it needs to be clarified. Many of the individuals here have trained from you and continue to do so. Me, one of them, not in 2004, by the way, 2000 for accuracy. Secondly, when I came to you, you were about much lower level than anyone in this room in your skill set. You were evolving. You had very little in terms of people leading you on. And I understand that, but you were our champion at the time. You were doing intradiscal approaches and had zero respect for anyone doing extraforaminal. I'm glad to see the society you've headed now has foraminal. I learned my foraminal techniques overseas and from Dr. Chu. And at that time, it was unacceptable to you. So the point I'm trying to make is this is an evolving specialty. And let's not be too cocky about other people trying to learn. I represent a skill set that you don't have, but let's not go into that. Because you're still our champion. Stay that way. Don't belittle the people here. Thank you.
Anybody else?
Okay. I said, I'm Al Rossi. I'm an attorney. I'm a member of the board of directors for SASI. In fact, I'm the one that coined the phrase that it's the voice of reason. And what I see here is I'm listening, and what Saul is saying is really on mark. And so with Jasper and also Dr. Kaul, this is an evolving, it's like the Constitution. The Constitution was an evolving document. I mean, there was no such thing as search and seizure under the Fourth Amendment. You know, there was no such thing as Marbury versus Madison, a writ of mandamus. There was none of these things when the framers first started. It kept evolving. What I'm seeing here, this is an evolvement process. I've listened to when you didn't have the proper equipment back then. Did that make it lack of a standard because you didn't have proper equipment, because the equipment wasn't in formation at that time? It's an evolvement, and that's what this society is about. It's evolving. And that's, and I think that, mimicking Saul, one of the things these people in this room are doing is evolving. And this word standard, from a legalized standpoint, the standard is evolving also. So therefore, if there's, my father was the AFL-CIO IUE union vice president. And now we can't use the word union with societies, but at the same time, it's a union of men, and men coming together, men coming under the rubric of medical societies. If you all form and come together, and you want to call it a standard, but it's really a policy. It's a policy of involvement. That's my statement here, but that's what I'm seeing is it happening. And that's what you need, is a cohesive unit. And I see the lack of cohesiveness. And there shouldn't be this fragmentation. It shouldn't be about dollars. It should be about treating patients. I've had many people in which I've defended doctors, and I've also defended patients against erroneous procedures. But sometimes there's a placebo effect. I've seen people give them a pill, and it wasn't anything, and they got better. What is the standard? Getting better? Because that's, as a legal perspective, even under New Jersey law, he has the right, he being Dr. Kaul, has the right to do surgery and medicine. There's all this configuration of what alternative privileges are, and what doesn't fit a standard. So if I seem a little upset, it's because what this is about is evolvement. And I think you should all work together. I'm going to let you proceed, but that's my perception at this juncture. I was making a statement. I didn't mean to be a rhetoric. It wasn't a question, but it is an evolving science.
I agree with that, and I'm giving you my personal biased opinion based on my training and my experience for the last 20-something years. So when you came in 2000, so did Gun Choi, so did Sebastian Rutten, so did all the people that you also learned, and they evolved the technique in their own way. So you don't see me taking credit for what you do. But I give you credit for having evolved this to the extent where you feel the need to form SASI. And my comment is that the process has been around for a long, long time. Maybe it's something that Nass and Eric Neubauer and all the new presidents going to take note of and see if there's enough time on the podium to promote this sort of thing. When I go to China, I promote it my way. When I give my workshops, I promote it my way. So I think there's room for discourse, and that's why I decided to come here. But you have my biased opinion. You don't have to agree, okay? And I think I hit a sensitive spot when I drew the line in the sand for fusion. I don't do fusions. I don't like it. But I grew up doing fusion before all the fusion doctors were doing it with cage rage and pedicle school rage. I did my fusions depending on my hands to do it well, and it took a lot of work. So what I'm saying is it's more complex than just putting in some hardware, okay? And so I think I'm just throwing it out there. I personally don't do fusions anymore. I used to only do fusions. I did it for barrels. And I did it when neurosurgeons weren't doing it. And I lived through the stage where neurosurgeons decided they want to do fusions and they want to do spine surgery. Yeah.
I think most reasonable spine surgeons do the best they can to stay away from fusions. The outcome studies for fusions for back pain, probably should never do a fusion for back pain when you actually look at the published outcome studies. Every surgeon that I've seen struggles with the indications for fusions for axial back pain. When it comes to decompression, destabilizing the spine, and then needing to utilize fusion for stabilization, there's no arguments to be had. There's indications for fusions and instability. And if you need to decompress and you're destabilizing the spine, there's indications for fusions. Whether you're a classically trained spine surgeon, I would agree that the classically trained spine surgeons who learn to do surgery a certain way, whether it be posteriorly, whether it be XLIF, whether it be a transforaminal interbody lumbar fusion, we've kind of crossed the bridge because as non-classically trained surgeons, for techniques that are not taught in their fellowship, these minimally invasive techniques for fusions. The indications for fusions and outcomes are clear. If your indications for fusing someone is back pain, your outcomes are going to be poor. Short term may be okay, long term, most of the time not so great, the indications for that. But drawing the line and saying, you're not a surgeon, you can't do fusions, I have a problem with that. In just basically, if you're telling me I'm doing a classically trained technique, maybe not. But the techniques that we're utilizing are not open posterior techniques. They're minimally invasive endoscopic techniques for the most part that the classically trained surgeons don't have the ability to do. So we've bridged a gap there. If I can do a fusion on a patient and maintain the structural integrity of their spine and cause less collateral damage, I think the patients have a significant advantage versus a classically trained surgeon who has only learned a posterior approach. They've been doing it for 60 years. I don't think they're doing the patient a favor. If I can practice medicine and do better for outcomes and taking care of my patient less invasively, that's best for patients. So if these things were part of the classically trained fellowship for surgeons, you'd see less of interventional guys doing the less invasive surgeries. It's not there yet.
Let me put it a different way. You have such a good method that you don't need to do fusions. I don't do fusions, even though I'm trained to do fusions. Why? Because what I offer with decompression, ablation, irrigation is better. And if they need a fusion, I'll send it to my son who only does fusions, and no one's going to argue the fact that if that's all you do, you're going to get the best outcome. And so what I'm saying is, don't be so anxious to do fusion. Why are you so interested? Because you get paid more.
Can I say something? I'd like to say something. I agree with you 100%. When I first started my practice in interventional pain, I was sending out hundreds of patients a year for fusions. In the last 2 years, I sent one patient for fusion with major instability.
Yeah. So why worry about fusion?
Well, I'm not worried about it. I'm not worried about it. I'm just worried about that line.
Right.
That's the only
what
thing
I'm saying is those guys who only do fusion will get a better result.
Any educated physician is not an advocate of fusions for back pain. It's simple. I remember your quote, Tony, from a surgeon who said it. First I fused, then I refused, now I refuse to fuse. If you look at the outcomes of these patients, as interventionists, we get all the failed backs. What do you do with them? Well, the best thing to do with them is prevent them. Now, most classically trained surgeons don't have the ability to prevent them because they haven't been trained on the less invasive techniques. If I could spend an hour and decompress a foramen without destabilizing the spine and fusing, I've done the patient a huge favor versus a larger surgery.
So
and it's
why
just
are
a
you
matter
so
of what's
interested
best.
in fusing?
I'm not. No, that's the whole point.
That wasn't the issue. There's the clinical discussion on the whys and wherefores of fusion or what's just been going on, but the use of the term drawing a line in the sand, when you said that, you didn't say at that time, I don't do fusions myself. So I think the impression you were giving was that there was a line drawn in the sand without any reference to your personal preference for fusions. Yeah. And I think that's the bone of contention.
Now, let it be known, on the record, I started out doing fusions before most of these guys did their fusions. I did it without hardware. I had to rely on my hands, okay? When I go to China, I make a joke. I have a Chinese brain, Chinese hand, Chinese work ethic. Nobody can beat me, okay? So, but I did that because I earned the right to say that because I went from fusion to non-fusion. But I recognize that there is a need for it. And if I had to have my wife have a fusion, I would send them to somebody who only does fusions because that's where you have the good results. And that's where the communication and the understanding is breaking down. Transforaminal approach, it appeals to interventional radiologists, pain management who have no formal surgical training but is familiar with needle placement techniques. So that gives you an advantage over the traditional surgeon. There is information and treatment procedural gap between traditional surgeons and interventional surgeons. So we're trying to fill that gap. I'm not trying to create any animosity, and I'm not going after Gabe personally, but I'm stating this as my personal opinion. So I'll respect your opinion, you respect mine, okay? But I'm older than you, so if you're in China, you better show your respect for age. Okay, so if you have the respect, we can talk. But if you want to challenge me as a student before you had a chance to hear where I'm coming from, then I would push back.
Okay,
so
let's
not
challenge each other anymore.
The right. Look at when an interventionalist decided to do epiduroscopy, they advertise this as using the foramen, the caudal equina, to remove disc herniations. Okay, I caught a prominent neurosurgeon talking about this because I was given the assignment. He used my slides without him knowing that was my slide. Now, that's plagiarism, but he's probably embarrassed if he knew that he used my slide to show what he was supposed to have done with the epidural scope. Okay? Sometimes things don't make sense. So I'm against using the sacral hiatus to do surgery. I'm okay for it to do interventional and to use for scar tissue and so forth. So these are the non-visualized techniques that have not withstood the test of time that most of you probably are much better at than I am. But they don't last, and what I'm trying to do is find something that's going to last. And I think we're in the same page when we talk about using the technique to do surgical validation. The literature review, we are dependent on that, supports transforaminal endoscopic surgery. They're level 1 EBM, 39 cohort studies, and their conclusion that there's no significant difference. But in my opinion, with my patients have greater satisfaction and less complications in my hands. So it's like Michael Jordan versus Shaquille O'Neal shooting a free throw. Okay? We all are on the same team, but we have to know our limitations. So on the left-hand side, endoscopic spine surgery. On the right-hand side, traditional surgery. There's no literature against the endoscopic approach. But what is in reality is that endoscopic spine surgery has a big gap between pain management and traditional surgery. That's where you're trying to promote. And we are not disagreeing. I'm just agreeing personal opinion on why do you want to go shift to the traditional surgery side when you can do 90, 80, some 70% of endoscopic by doing decompression, ablation, irrigation. Okay? So why are we talking about fusion? We shouldn't even be talking about it. We're both saying that that's a last resort, really a last resort, but not surgery. Surgery is a first resort. You got a BMW, you want to take care of it because it costs them so much money. You don't want to wait till it stops running and then decide to fix it. So diagnostic and therapeutic injections help predict the surgical outcome. I'll go through this really quick. You have to do it the way you put the needle to do the surgery. Every guy, even Steve Levine, has a hard time switching from the down the tunnel Scotty Doc approach because you don't have the right trajectory. I'm saying you got to get the right trajectory. And so if you do that, you can get information that will tell you about lateral stenosis and central stenosis and recurrent herniation. And look how far I put my needle. It's got to be done a little different way. And when you do that, you outline the foramen, and you're going to be able to, using this technique, to be able to diagnose lateral stenosis, central stenosis, bulging disc, and you get results from your intervention. Here is a recurrent herniation. When you put your needle above and behind the retrieval body, you get a discogram. So that tells you there's communication from a disc herniation. So all these things take time to learn, and you learn it by being able to visualize the pathoanatomy. So I'm going through this really quickly to show you that there is a difference, even in IDET. IDET is a good concept, but it doesn't really work well because you haven't taken out the disc material that's keeping the tear open. You got to do that mechanically. And then if you understand that, you're going to abandon IDET and you're going to do SCD with annuloplasty or disc fix or some other technique that is made for interventional spine. So the evolution is not only no blood loss and so forth, but you got to prove efficacy. And you got to show that by identifying what you're doing. And now that you have an endoscope, you can document, okay? And that becomes surgically based evidence. And if you do that, you can even do fusions, okay? So you evolved to do that, but you know how to get there. I don't have a problem. But right now, there's a turf battle between traditional surgeons. You're not going to convince them that you're as trained as well as they are. That doesn't mean you can't do it. But I'm saying that you have so much going on the left-hand side of the column. Why do you have to worry about it? Okay? So the endoscopic transforaminal approach, I give you credit. Augmented by modified pain management techniques. Modified means you modify it to do surgery through that same approach that you put the needle. Okay, and you have to combine these techniques with discography, with epidurography, with epidural blocks. Okay, foraminal decompression guided by needle trajectory, by decompressing the foramen, the disc, the annulus, and in the process, you can ablate the nerves that cause back pain, and you can see the nerves. Okay, I've shown that over and over again. Global published literature supports all that, and you've shown that you go to Germany and you learn full endoscopic approach. Rutan was my student as well, same time as you. So was Gun Choi. Okay, and the only one that didn't learn from me is Hubland. Even Martin Knight learned from me, but he using the laser do foraminoplasty. He's not accepted, but he does good work. That's because he's so dependent on the laser. So you have to be flexible. You have to use everything at your disposal. So, because I'm using pain management approach, I never took a single pain management course. I came upon it myself. So don't claim that I learned from you, okay? Because I did that, and we just evolved the same way, okay? So anyway, let me have my say. So now these new techniques are, I acknowledge the fact that you can now do a fusion percutaneous under local, and I proved that by doing it myself, even though I don't do fusion. So when I proved it, and I can show you video on it, that it can be done, it's a technical exercise, but I don't know all the facts about fusion, not as well as Scott Bowden and all the guys who spent all their time studying how to get a fusion with biologics and so forth. Fusion is complex and beyond the scope, in my opinion, of non-surgeons, even those with technical ability, and I have technical ability, but I don't know as much about fusion than my son or my colleagues. Nucleus augmentation, that's maybe the future. Dynamic interspinal spacers, that's here. DRG neuromodulation, those of you probably owe a lot of your practice by putting spinal cord stimulators because of surgeons. Now, you can do one better. You can put a little electrode by the DRG and have a battery pack and be able to do it much cheaper, much faster, and much more efficient by stimulating at the DRG rather than the spinal cord. And this, I have a patent on that technique, by the way. And so why MIS from a marketing approach? Patient demand. You get patients who come to you and they want you only because of what you did through the friend. And I agree. Less blood loss, quicker recover, return to work. That is too low a threshold. You need to have more than that. You have to have patient safety and effectiveness that you can support. If you can do that and you guarantee your results, I have no problem. Okay? So if you do the most simple standard, I want you to raise that even more by saying, we're going to do it safely and effectively, cost effectively, and as well as procedure effective. So minimally invasive can also be minimally effective. That's why I'm saying don't lower your standards, raise your standards. Guidelines set by SASI is oversimplified, in my personal opinion. You don't have to agree, but you asked me to give my opinion. I can't give you an opinion that agrees and everybody says kumbaya and we all go home. Okay, so anyway, I think the surgeon technique, Walter is doing this approach. The anatomy is the same, and I'm showing you even my technique has evolved. And like you said, what I did 20 years ago is not the same as what I do now. You have to know the anatomy. It comes down to anatomy and learning the skills. And the Scrambled triangle has all kinds of pitfalls, including peripheral nerves and anatomic variations, the difference between normal anatomy and abnormal anatomy. Then you have to do it under local anesthesia. If you do that, you don't need neuromonitoring. Okay, I've done a study, and it's not needed. So basic indications, here they are. Example, this is the one that's Soul Watch, because I have your picture looking at me after I took that out, and you go, yeah, you got your thumbs up. Okay, I couldn't find that video. Anyway, that's a far lateral herniation, and this is the fragment that I got. Here's how I do stenosis, and it's just simply the same thing using cannulas, Kerrison's tools that allows me to do the decompression. And these are techniques that I can show you, but we're running out of time, so I'm not going to show the technique. But my basis of what I'm saying is I can prove what I did because I videotape everything. I have audio, I talk to the patient, and you can see that on every one of my surgeries, okay? So I want you to do the same thing, then I will be a believer. Steve has watched me a lot of times, and I can't stop him from talking because every time he gets so excited that he wants to go, oh, look at this, look at that, see? So I want you to be that kind of enthusiasm, with that kind of enthusiasm to show what you're doing and showing it on videotape. So surgeon skill, experience is critical, but experience is more critical than skill. We all can develop that, okay? You have to consider yourself like highly paid professional athletes. Anything, concert pianist or high level basketball, LeBron James and that sort. You want to strive for those standards, not the standards of just playing basketball in Little League where everybody has to feel good whether they're lousy or not, okay? So I have also developed techniques for all pain management to safely be able to do these procedures by starting with a percutaneous procedure that is fluoroscopically guided that gives you the same results as the visualized approach. So is there a turf war? Yes, maybe, but it shouldn't be. I think the standards of training is needed somehow to protect our patients from unqualified practitioners. All of you here are qualified, but how many interventionists do you feel the same way? So credentialing may be politically polarized between specialties and individual practitioners. That's where the lawyers come in. You know, we can't do anything without our lawyers in our own gladiators, but the lawyers can defend a murder and they feel good about it. That's their system. Okay? Even though you know they're guilty, but that's what their product. We think differently. We think that we need to protect our patients and give them good results. Regulators, payers, everybody's in the mix. So it's economically motivated. That's our system. Basically, I raised more questions than answers. And this is what we hope we can come to some kind of agreement with the discussion. So thank you for your attention. You gave me the podium. Take that. Personal opinion is nothing personal. But if it hits a nerve, I've done my job. Thank you.
Thank you very much, Dr. Young. Your lecture and your speech are well received. And like you said, you always like to be, at a minimum, controversial. You've done a great job of that in pointing out all the nuances, all the various nerve endings have been exposed endoscopically.
So you've seen all that. So.
You can tell Tony's not a neurosurgeon. Neurosurgeon's never touched him.
Yeah, that's right. That's right. So
let's thank Dr. Young.
we thank you greatly for this. At the end of the day, Dr. Young is one of us. And I am glad that he is, as usual, brave enough to touch nerves. And his point about being the star players rather than just average basketball players, using his analogy, is correct. Whether you're an orthopedic surgeon, neurosurgeon, interventional pain, interventional physiatry, whatever you are, if you have the skill sets that you've learned, acquired, this should be continued to be improved upon. This is an evolving specialty area. There is a gap that's unfilled, that can be filled. We welcome NAS. We want to be cooperative and want to be an integral part of moving this field forward. Thank you all.
Everybody ready to go? I'd like to thank SASI and Dr. Campson for inviting me to speak here today. Let me just tell you a little bit about my background so you know who's talking to you today. My name's Jeff Randolph. I'm an attorney. I practice in New York and New Jersey. I've been practicing for 16 years, and I primarily focus in medical malpractice defense of surgeons as well as surgery centers. So I've been in the trenches and in courtrooms fighting the battles with regard to doctors where there's allegations of lack of privileges, lack of qualifications, things of that nature. In addition, a lot of times the surgery centers get brought in also because they're alleged to have committed improper credentialing or allowing doctors who don't have board certifications to perform surgeries in their surgery centers. So it is a pretty contentious topic. I also do a board defense because a lot of times when a doctor has one or two or even more malpractice cases, they get pulled in front of their medical board and they're looking at a license suspension or getting the license taken away. So I do license defense also. I represent about 5 or 6 surgery centers as a general counsel. I also represent the New Jersey State Chiropractic Society, and I drafted their scope of practice legislation, drafted numerous regulations. So I think I have a pretty good perspective about what's going on today with a lot of the turf wars we're talking about. And one thing I want to start with before we get into the slides, I think there's an important distinction we need to look at. I'm going to be talking today about a lot of the legal standards. Legal standards are the absolute minimum. That's something that a doctor has to comport with to maintain their license. I believe what SASI is talking about is you're looking at establishing best practices. That's something above that minimum legal requirement. So, I mean, keep that distinction in mind. When I'm talking about statutes and regulations, that is the absolute minimum the doctor has to comport with to maintain their license. When we're talking about establishing guidelines or certifications, that's best practices. That's something that's much higher than that. And I think that's what SASI is trying to do. You want to establish best practices. You don't want to establish that bare minimum. Okay, just going to little history. The other speaker talked about this before, Tony did, about the turf wars. We've had medical doctors versus chiropractors. And one thing I want to talk about quickly is a case from 1987. It's called the Wilk case, and it does concern chiropractors and the AMA. And actually, back in 1987, the chiropractors sued the American Medical Association for anti-competitive practices. And what happened in that case is the chiropractors thought there was a concerted effort by the AMA to basically put down their profession, and they went to a judge and they actually got an injunction. And for the attorneys in this room, an injunction is a pretty hard thing to get, and it was a permanent injunction. It was entered against the AMA where the court said that the AMA had engaged in a massive disinformation campaign to discredit and destabilize the chiropractic profession. This is a reported opinion. It went up to the appellate division, and it was affirmed by the appellate division. So this is the law of the land. And there is precedent now that there are these turf wars, and if you go too far, you're actually committing anti-competitive practices. It's in violation of the Federal Sherman Antitrust Act. A couple other examples. I mean, physical therapists, the Physical Therapy Association has a 10-year plan where they're looking to get a number of things. They want to obtain direct access, and I know a lot of states now have direct access for PTs. You can go right to the PT without a doctor. A lot of times you have to go to the doctor after 30 days to get a renewal, but you can get direct access to the physical therapist. They also want to obtain physician status, so they want to be called doctors. That's something they're striving to get in some states, and it's very close in some states where they will get doctor status. They will be able to diagnose. They also want to expand their scope of practice to include medical procedures. They want to draw blood. They want to do dry needling techniques, and they want to also diagnose, like I said before. So they're really pushing the envelope, and they want to get full physician status in a lot of states. Not only is there infighting amongst the different specialties, there's also infighting amongst the medical doctors, and that's a couple examples here. Neurologists versus PMR doctors. So there's fights in New Jersey and some other states about who can do an EMG. So can a PMR doctor do it? A lot of insurance companies don't want to pay for it if it's not an actual neurologist doing that test. And then finally, the turf war that we're talking about here today. We're talking about the minimally invasive spine specialists versus the neurosurgeons and the orthopedic doctors. Now, it's a very basic general constitutional tenet, just going to the basics of the law. The powers not granted to the federal government are reserved to the states. So what we're talking about here is federal law does not really define scope of practice. So I can't stand up to here and tell you there is one scope of practice for the entire nation. We have to look at every single state. Each state may have a different scope of practice, so you really need to look in the particular state that you're practicing in to see how is that scope of practice defined. Okay. There are federal laws which touch upon medical practice, things like the HIPAA law we all know about with patient confidentiality, patient notification. There's also the Affordable Care Act called PPACA. I'm going to talk about that in a little bit, how that does affect some medical practice as well. And I want to go into a New Jersey example because that's where I practice most of the time. Now this is the actual New Jersey statute, so if you can take a look at the language and I'll read it for you. It says the practice of medicine and surgery shall include the practice of any branch of medicine and or surgery and any method of treatment of human ailment, disease, pain, injury, deformity, mental or physical condition. I don't think you could get much broader than that. That basically says if you are a doctor licensed in the state of New Jersey, you can do anything you want. It's a plenary license, and here's the definition. It's from the Latin plenus, meaning full, entire, complete, absolute, without limitation. Okay, so there really are no limitations or certification requirements. And I mean, theoretically, a general internal doctor could perform brain surgery. I wouldn't recommend that he do that because he would be getting himself into a lot of trouble. But under our law, as it's defined, a doctor who has a medical license can do whatever they themselves think they're qualified to do. It's kind of scary that it's drafted that way, but understand this statute was drafted in 1947. There has been no change since 1947 on the statute. And the issue is that this is what doctors have to look at in our state to decide what they have to do to comport with their licensure requirements. There's a process. If our state wanted to change that, there's a whole legislative process. So you go to the House and Senate, you get a bill passed, it gets signed by the governor. You can change this. The problem is it hasn't been changed since the end of World War II. Okay? Just talking a little bit about the turf war we have between the different types of doctors. And one of the issues I have as an attorney is that this is not defined in any type of regulation or statute, what a doctor needs to do certain types of procedures. So it's really a de facto standard which is being applied by the medical boards, by the courts, by anyone else who's looking at this. And that has some constitutional issues because there's something called notice. A doctor has to have notice of what they have to do to comply with their laws. If they don't have that notice, any type of law could be void for vagueness, it's called. So if we don't have a good statute which defines what the doctor has to do, if we don't have good regulations which says you have to have a certification, you have to have a certain number of hours of postgraduate training, you have to have a fellowship, doctors who are doing these things are technically in compliance with the law. Okay? And I have here that there is no such board certification or fellowship requirements in the state of New Jersey or in the state of New York, so any type of statute or regulation, if it's not in there, it's considered ultra vires, which is beyond the scope of that regulation or statute. Okay, so doctors are being held to these standards which are beyond those statutes and regulations. Okay, now I was involved in some board actions regarding minimally invasive spine surgeons, and here's some of the facts that came out during the case, and then I'm going to talk a little bit about a malpractice case that I was involved in as well. Okay. The arguments were that the orthopedic and neurological surgeon's argument was flawed. Many of those surgeons now pushing this argument, they finished their residencies back in prior to the 1990s before this was actually taught in school. So there really was no specialized training in doing these minimally invasive procedures. Okay? There is no type of board certification by the American Board of Medical Specialties. That was brought out in the case as well. And also that the interventional pain management doctors and anesthesiologists, they actually have more training in fluoroscopic guidance than the surgeons do. So these were the facts that are presented to the judge. The judge then uses that and he's going to make a decision. And also one of the problems is we have a judge who's deciding this and he has zero medical training whatsoever. He's a lawyer like me, never gone to medical school. He may have taken a couple continuing education courses in medicine for lawyers, but that is who's going to be deciding this case. So, I mean, one of the critical things the attorney has to do is explain these things to the judge and hopefully educate the judge as to what the standards are, what the law requires, and then hope you get a good decision. Okay. Now, Saul talked about the definition of minimally invasive spine surgery, and it was the 5-factor test. Actually, 4. Yep. And I just want to make a distinction here also that, I mean, basically, this is the definition. So if I'm an attorney in court, I first have to go to the judge or the jury and say, what is minimally invasive spine surgery? Here it is. We have a definition. This is something that doctors agree upon. We have to go beyond that, though. This is not a standard of care. This is a definition. This is step number 1. Second step is, who is a minimally invasive spine doctor? Who can be qualified as an expert to testify as to what the standard is? So we need to get to step 2 also. We need to define who are these experts. Can you have a board-certified orthopedic surgeon testify against a minimally invasive spine surgeon? In our state, we have a same specialty requirement. And if the judge, as a gatekeeper of evidence, determines that a neurosurgeon or orthopedic surgeon isn't the same specialty as a minimally invasive spine surgeon, they can't even testify. They would be barred from testifying. So that's step 2, and that's something SASI would have to do, is define who is a minimally invasive spine surgeon. We have what it is, who are these doctors, and who can qualify as an expert to testify. And then we get to the third step, and that's where we get to the standard of care. So what is the standard? That standard is going to be much higher than that base level of legal requirement, but what exactly is that standard? So this definition here is not a standard. SASI needs to get there or NAS needs to get there. Somebody has to actually define the standard that you're holding the doctors against. And that also raises a slippery slope issue, though, also, because I mean, the societies have members. You don't want to have that standard completely way up in the sky, because you're going to have members then that don't do everything in accordance with those guidelines, and it's going to be held against them in court. But on the other hand, you don't want to have it at the minimum legal requirements, so you need to kind of reach a balance, you know, somewhere in the middle to high middle, where the standard would be set, where this would be the best practice, and you're not going to affect a lot of your members and have something held against them. Because that's a very easy thing for me to do in cross-examining a doctor, is if they admit that they're a member of a society, and that society has a guideline, and they didn't follow that guideline, that's a slam dunk. Case over. The jury would find malpractice. Microphone?
Addressing basically is standards that we're talking in a court of law.
Right.
At this juncture. However, you know, you address on several levels. You also represent people in front of medical boards and in front of the OAL, the Office of Administrative Law. I don't think that, I don't know if this audience is familiar, but the OAL is under the executive branch of government, especially in the state of New Jersey. And the medical board is also not an elected board in the state of New Jersey, which may be an anomaly nationwide. Can you address some of that too in your
Sure. Yeah, I mean, what Al's talking about is when doctors have an issue with their license, they have to go in front of their medical board, which is part of our executive branch, which is the governor is the top of the branch. They then the medical board sends them out to an administrative law judge. They're not essentially a judge. They're appointed by the governor. They're political animals. They don't have, you know, formal judicial training. So they're actually finding facts and making decisions of law where they work for our executive branch. And it's almost like a kangaroo court, because you don't have really full judges making these decisions. They work for the same branch of government that the medical board does. And then it's really an unusual setup. And I mean, I'm sure no one's really surprised here. New Jersey has some corruption in it, but I mean, we do have a little bit. And there is some political issues going on. So a lot of times the appointees to the board, they may be there for political purposes. They may be there for other purposes. They may be there to protect their turf. They don't want other doctors honing in on their business. So that's the things we face, and it's really hard to disqualify a judge. So I mean, even though you may think these things are going on, getting a judge to actually be disqualified is very hard to do.
And in addition, just a comment, and I'm sorry for interrupting your plan of action. The OAL, after the decision is made, it goes back to the medical board. And for its final determination after the decision is made by an officer, so you go through a whole process. The trial is held.
Right.
It comes to a decision, and then the medical board has the final say after you've already had a quasi-judiciary branch under the executive branch come to a decision. And then you can go to the appellate division.
Right. Yeah, I'm not sure if every state's like this, but at least New York and New Jersey, even if an administrative law judge clears the doctor of any type of wrongdoing, the medical board has the authority to accept, reject, or modify that decision. So they can say, listen, Judge, I know that you sat through 30 days of testimony, you heard the witnesses, you assessed their credibility. We disagree with you, and we're just going to reject it completely. So it's very, I mean, the judges are given very broad power, and they're not true judges. So it's an unusual system, the way it's set up. The remedy for that, though, is changing the system, and that is a long process. It's changing the laws and everything, but I'm going to talk a little at the end of my presentation about what are the possibilities of things that can be done about this. There we go. Next slide. Okay, so first thing we can possibly do is legislative initiatives. So, I mean, if you have a strong organization, you can engage state lobbyists to clarify and strengthen the state scope of practice laws. As I said before, we have a scope of practice in New Jersey that was written in 1947. It's about time to get it updated. It may not be a bad idea to do that, and professional societies, in many situations, they actually draft the bills, present it, you get a sponsor for it in the state senate or the state assembly, and then you get, you want a bill that you want passed, and you have good things in there, you can hopefully get it passed for you. Update your scope of practice. You can put minimum requirements for what doctors can do. You need to update it from the 1940s. Okay? Revise the medical board statutes to clarify the board's role in implementing the scope statutes and strengthen conflict of interest prohibitions. That's one of the problems is we have doctors on the board who they do have essential conflicts of interest. They're making decisions about doctors who are their direct competitors. They're somebody who should recuse himself from the board, or they should not even be on the board in the first place. Most states don't have statutes which mandate that recusal. So you have somebody who's your direct competitor determining whether you have a license or not. Seems inherently unfair, and that's something that you can address through the legislative process. Okay, federal lobbyists, if you want to make some changes to federal laws, you would have to have a federal lobbyist to do that. But now we're talking about 5, 10 years to get something done federally, and a lot of money to engage a very well-known lobbyist. So that's not something easily done. Okay, I just have an example here that the Affordable Care Act, but really the intent is to reduce the costs and the impact of medical services. So this really supports the promotion of minimally invasive spine surgery because you get the patients better quicker. You're much cheaper than doing it in a hospital. So that really the intent of PPACA should be behind promoting minimally invasive spine surgery and allowing doctors to do it. Okay, next thing, regulatory initiatives. Okay, enforce the regulations as drafted and oppose de facto standards being applied by the board. Like I said before, none of these requirements that the doctors are being held to are in the regulations. The board's making it up as they go. That legally is not permissible. It should be enforced. The letter of the law should be enforced. The board should be held to. You enforce what the law says. You don't make up a new standard as you go along. Okay? There's a mechanism in the regulatory field where you can file a petition for rulemaking. So if you don't like the regulations in your state, you can actually petition your board, your medical board, to change those regulations, and you can give them proposed language. That's a very effective process, and that's something that doesn't take a lot of money and a lot of time to do. So as long as you have a decent medical board, which will have an open mind and look at these regulations, you can petition your medical board to change those regulations. Okay. File complaints to authorities overseeing the boards concerning conflicts of interest. Like I said before, most boards have an ethics officer. They have ethics guidelines. So if you feel that a doctor has a conflict of interest and he's on your case, or if you think they shouldn't be on that case for some other reason, you can bring it up to that ethics officer. They'll research it, and if there isn't, in fact, a true conflict of interest, they'll tell that doctor they have to get off on that case at least. Okay? Then lobby to obtain a seat on the board for minimally invasive spine surgeons. I mean, get a seat at the table. There are all types of doctors on the medical board. I can probably guarantee you in most states there isn't a minimally invasive spine surgeon. So get somebody on the board there. You'll be there. You'll hear what they're talking about. You'll have a vote. You'll have a voice at the table. That's, again, something that may be hard because there's a lot of politics involved. But if you do have societies or doctors who have some political clout, you can get somebody on the board, and then you have a seat at the table. Legally, as you can go to an attorney, what can you do with an attorney? So the reason I talked about Wilk before is that basically that's a precedent for anti-competitive behavior. So if it goes too far and there actually is a directed effort to oppress minimally invasive spine surgeons, the Wilk case does establish a precedent where there could be a violation of the Sherman Antitrust Act. Okay? Possible lawsuits against the medical boards if they are, in fact, going beyond the scope of their regulations and their authority in performing ultra-virus actions. You have the ability to sue the medical board and get a declaration from the court saying you cannot do that. You need to enforce the law as written. Okay? And then something that was mentioned before, defending those individual malpractice cases. So as an attorney defending doctors, it's very critical that I have a group of experts who are the same specialty who can then look at the medical records, look at the films, look at the outcome, and give me an opinion as to what that doctor did and whether it deviated from the standard of care. Having a society like SASI or NASA or anybody else that can give me those experts, that's a great help for me to do that. But then also, I need national guidelines or even state-accepted guidelines those doctors can reference. Because there's also a basic legal tenet called a net opinion. A doctor can't just sit on the witness stand and give an opinion without any backing for it. That's considered net opinion. It's not admissible. They have to be able to reference some type of peer-reviewed literature, some type of accepted guidelines, something like that, or else the doctor's testimony won't be accepted by the judge. If we can establish some type of national guideline like that, that's something the doctor can hang his hat on. He can reference that. If we can get the doctors here published in peer-reviewed journals like was discussed before, that's another thing the doctor can hang his hat on in court that will get that testimony accepted. Okay. And here's just very briefly a malpractice defense example. So I mean, just the fact pattern on this one, and then I'll be concluding, is that a minimally invasive spine surgeon was sued in state court for malpractice. So it was a general malpractice case by his patient. The patient alleged that the surgeon, despite having thousands of hours of education, having previously performed hundreds or possibly even thousands of these same type of procedures, that they weren't properly trained. Okay, he shouldn't have been doing that type of procedure. He wasn't a board-certified orthopedic and neurological surgeon, and he didn't have hospital privileges. So based upon that, the patient sued the doctor for malpractice. The demand before trial was in the multi-millions of dollars. The patient would not budge. Wanted in excess of $3 million to settle the case before trial. Case didn't settle, went to trial for 6 days. Okay. I was the attorney defending the doctor in this case, and there's something at the end of a case called the directed verdict, and what that means is once the plaintiff presents their case, and then I present my defense, I can make a motion for a directed verdict, which is going to the judge and saying, listen, judge, this case is so one-sided, you have to rule in my favor on these issues. So I made that motion for a directed verdict, and it was on the issue about credentialing and training. I wanted this to be a very simple negligence case, just malpractice. It shouldn't go to the jury that this doctor wasn't appropriately trained, wasn't appropriately credentialed, didn't have hospital privileges, and in fact, the judge ruled in our favor. So we got a New Jersey judge to rule in our favor, and I quoted some of his exact holding from the court transcript. And here the judge said the licenses in New Jersey, the law is well settled on this, are plenary, and the doctor can perform anything the doctor can do. So this is a judge now defining what can be done in the state of New Jersey. The idea that someone can walk into a court who happens to be an orthopedic or neurological doctor and say that he, talking about the defendant, cannot do this kind of procedure because he does not have this kind of training that I had, or that the hospital insists on, I think is not a standard of medicine at all. So the judge concluded, so I think that not as a medical issue, but as a legal issue, the expert was expressing an opinion on something he had no right to express an opinion on, so I reject that. So based upon that decision, the judge threw out all the issues about credentialing, training, hospital privileges, and it went to the jury on straight negligence, which is really what we need to do for doctors, because if the doctor's meeting those minimum legal requirements, even though he's not meeting best practices, he's meeting those minimum legal requirements, and he should not be penalized in malpractice, because the law requires a deviation from the standard of care, and the standard of care is what does your law require. Again, so we got a great decision in this case. Unfortunately, it doesn't happen all the time, but this is something critical for doctors that are going through these types of issues. Doesn't matter if it's in New Jersey or New York, you need to basically go to the judge. You need to have good experts to tell him that this is a legal issue. It's not a medical issue. The law requires, or at least in our state, that if the doctor is doing what his statute says, he can do it, and he shouldn't be given a multi-million-dollar judgment against him for malpractice. Yeah.
How do you feel about the caps on medical malpractice insurance, if you don't mind me asking?
Medical malpractice caps?
Yes.
That's a hot topic.
Yeah.
We don't have them in New Jersey. I know
Correct.
a lot of states are doing that to try to reduce the outrageous plaintiff verdicts. I don't personally oppose them, but I mean, that's it. It will help keep doctors from practicing defensive medicine because they're concerned about, you know, potential malpractice. But I mean, you really have to weigh it, because the plaintiff's bar will always tell you that, okay, at least people are hurt, they're permanently damaged, they're never going to get better again. They can't have a $250,000 cap. But it's really a political issue more than a legal issue. So I know everybody's looking to reduce the costs of medicine and litigation. That would help. But is it going to negatively affect too many patients? That's the big issue.
Okay, thank you.
Okay, sure. And then
Jeff, could I just say on that point that Al brought up, in the 2,700 page document that is the Affordable Health Care Act, which was completely political, they completely ignored any opportunity to bring about tort reform, because in the words of Nancy Pelosi, the evidence did not support malpractice claims as being a driver of healthcare costs, which I found quite surprising.
Right. So that is a pure political statement. I'm sure. I mean, we don't know if the facts back that up or all, but I mean, there's been many fights about that, Doctor.
I have a practical question. In an administrative law judge, you can have completely conflicting testimony by two experts.
Right.
And finally, the judge says, so-and-so is more credible, so I accept his, but he has no training. And so I know some judges, you flip a coin, one time it goes one way, one time another way. How do you solve that problem?
The problem with that is basically changing the regulatory and statutes in the state law, saying that judges, giving standards to them, possibly having some minimum type of education requirement for them, maybe requiring if they're going to hear medical cases, they have to have some type of medical background, you know, whether it be certain types of training. But that's the coin flipping does occur.
Yeah.
I know, but it's a hard issue to address. But establishing standards for the judges would help also, because we have a political appointee judge who has no training. He's flipping coins, making decisions. That's not right.
As a lawyer, like in malpractice cases, the expert can say anything he wants. He can accuse the guy, the other side, of being a rapist, and he has absolute immunity. Do most states have that? And when you rely on the judge to be the gatekeeper of information by eliminating certain evidence and limiting and others not, the judge is not trained to do that. So sometimes he tries to play King Solomon. He allows something in that he shouldn't and excludes others.
Right.
And so it becomes a game between lawyers who are fighting to win, not for what's the appropriate decision.
That's a very good point, because each lawyer is pushing the envelope to see what they can get in. They want to inflame the jury against the other party, and that they try to mean. And a lot of times,
Exactly.
But one of the standards the judges are held to, though, it's better to admit something and then try to cure it later with a jury instruction than not admit it at all. So a lot of judges will lean on the side of, I'm going to allow it, but later on I may tell the jury when I'm charging them that disregard that because that wasn't relevant, or disregard that was inflammatory. But once the bell is rung,
That's it.
you can't.
As a lawyer, would you support truth in expert witnesses so if they can be caught lying, that they would throw out their testimony and also be sued?
Absolutely, I would support that completely. Ethical guidelines with regard to expert witnesses.
Does New Jersey have that
We
guideline?
do not have that, and like you said, Doctor.
In Arizona, they do. Yeah.
It's open game, so they can say whatever you want. I mean, I can make a motion to the judge saying that there's a Rule 403, it's called, which is that that testimony would be prejudicial, and it exceeds its probative evidence towards the jury, so I can get excluded based upon that. But they're saying anything they want and then hoping the jury instruction is going to cure it, but the jury heard it. It's not going to help. So having standards to hold them to, I would love to be able to make a motion at the end of the evidence and get that all kicked out.
What happened in Arizona, I supported a bill to take away absolute immunity for qualified immunity. It was opposed by our malpractice carrier and our medical association, which means that they needed their whores more than the other side.
Good point. Yeah.
Jeff, I have a question. You turn that off. You raised the issue of defensive medicine. So under the old system of payments to physicians, they got paid for every procedure they get. If they got paid for doing the procedure, the more procedures they get, the more defensive, the better defense they had if they got sued.
Mm-hmm.
We're now moving to bundled payments and episodic pay. So getting paid for doing a certain number of procedures is going to go away. How do you think that's going to influence malpractice?
It's hard to tell now, but I mean, since they're shifting away from fee for service and for pay for performance or pay for results. But I mean, I don't think it's going to affect it greatly, because if the doctor's teetering on the edge about, do I get the MRI or not, just to make sure that I didn't miss something, they're still going to have in the back of the mind, I'm going to get it anyway, even though it may push down my reimbursement by 0.5%. I'm going to get it because if I miss something, I don't do the MRI, and then I'm sued and I have to pay $1 million judgment. It's well worth it. So I think, the doctors are going to be making a risk-benefit analysis in their minds, and they're going to say, well, if I overutilize MRIs and it's only going to reduce my reimbursement by 0.5%, I'm going to do it just to cover my butt. If it's going to penalize them by 20, 30, 40%, that may be a different story. But that risk analysis judgment has to take place with the doctor. Okay, that answer it. Okay, I have here SASI.
Excuse me, Jeff.
Oh, sure.
One of the things about the qualified immunity, even in testimony, if somebody is overstating a position, I understand that the prejudicial effect outweighing the probative value that the court can admonish and try to cure. But as you just said, if you hear the bell rung, you can't unring the bell. Right. And as the doctor was just saying, there still is, when most people don't implement it, if you make a complaint or file a complaint and there's all these mischaracterizations in there, it hasn't been implemented, but it is still a qualified immunity. You can't, you can't just overreach, because then you are subject to libel, you're subject to other things. And, and I've implemented those kind of suits where people have overstated their position, and and you can issue some kind of, there is a retaliatory mechanism. Most people don't implement it, but there is a retaliatory mechanism. And also, when I used to be a prosecutor, and if you have to reach certain parameters. I was the municipal prosecutor for the city of Patterson. I was with the U.S. Attorney's Office, and I used to do white-collar crime. I was an intern there. I was with the Essex County Prosecutor's Office. I was a detective there. So even in our preparation, when you put something into evidence, there is a distinction which should be drawn even here. In a court of law, you have the rules of evidence, but truthfully, only things come in under the rules of evidence. So when you're talking about the truth is weighed by the rules of evidence in the court of law. In the OAL, however, there is a relaxed You can, I've entered hundreds of exhibits in OAL, whereas they would have never got in the court of law, and yet a doctor, and doctors are sitting in this room, are now being judged by that judge that there is no standard for complete evidence rules, and that license can be taken under that standard. So there's all this, you know, we have there's no set standards,
Right.
and using the word standards across the board. Go ahead, Jeff,
Yeah,
I'm sorry.
that's one of the issues, and that's why I have here that mean it's better to establish your own standards than have someone establish it for you. Because you can then determine where between that legal minimum and the absolute best practices do we want to set that standard? Where on that range should it be? So I mean, do it yourself. Don't have it foisted upon you by someone else. It's a good idea to establish a standard. Again, I'm not advocating setting it the legal minimum. I agree with the doctor in that point. It's me just saying that definition is a standard. It's not. We need to establish a best practices standard, not too high, but something that 99% of the doctors can meet, and it will be in the best interest of the patients to do that. Okay, and I just referenced here the medical necessity definition for Medicare, which actually does reference the medical society standards. So even though medical necessity is defined by the Medicare statute, it does look to medical society's guidelines and standards. So as NAS or SASI, you can establish a guideline that's incorporated by reference into the Medicare definition of medical necessity. And that can help with reimbursement, it can help with malpractice cases, anything of that nature. Okay, and finally, the AMA is 1988 Medical Necessity Resolution. Again, that says standards should be set by physicians, shouldn't be set by anybody else. I mean, interesting thing in New Jersey, we have guidelines for the treatment of auto accident patients. They were actually written by PricewaterhouseCoopers, which are accountants. They wrote our medical guidelines, and they are our law. So that should not happen, and hopefully won't happen anywhere else, but physicians should be writing these guidelines, references to medical societies. So again, this resolution looks to medical societies to basically help establish that guideline, that standard of care, and that a physician of the same specialty should be the one who's involved in deciding about these guidelines. So again, we need to define what the same specialty mean for minimally invasive spine surgery. Does it incorporate all these surgeons? Does it incorporate general surgeons? Or is it just minimally invasive spinologists, as somebody couched before? Okay, that's the end of my presentation. I'm going to turn it back over to Dr. Campson.
I'd like to ask a quick question before you go. I understand that you represent chiropractors in New Jersey.
Yes, I do.
Are they allowed to do spine procedures like injections?
They cannot. They have a non-plenary license. They can do anything except prescribe medication. They can't do any surgery which requires cutting. And there's also a statute which doesn't allow EMGs, but they can do anything else besides. But they can't do epidural injections. They can't do trigger point injections. The only real piercing of the skin they can do is to draw blood.
How about acupuncture? Can they do acupuncture?
Acupuncture, no. We have an acupuncture statute which makes it a crime to actually practice acupuncture without an acupuncture license. So based upon that statute, unless a chiropractor goes and gets an acupuncture license, they can't do acupuncture.
Fascinating. Thank you.
Okay.
Excuse me, Jeff. As to the reading of films, years ago you just brought the chiropractor in, he was able to read the films. Now there's a change in that. Can you elaborate on that a little bit?
Chiropractors in New Jersey a lot of judges are not qualifying them to read the actual MRI films. And again, and if they just rely upon the radiologist report, it's considered hearsay. So you actually have to, as a plaintiff's attorney, you have to pay the radiologist, $5,000 to come into court to just put the film up and say what it shows. But now there's been, a lot of judges are refusing to do that. We've actually been trying an initiative with the Chiro Society to put together a MRI reading program, which is taught by a medical doctor, a 30-year veteran of reading MRIs, and hopefully get a certification together which will stop that. So now, there are some courts which allow them, but the vast majority will not allow a chiropractor to go up and put the film up and say, I see a herniation.
Exactly. Thank you.
Okay? Thank you.
Thank you so much, Jeff. That was very educational, very illuminating on a lot of the issues. And it raises, again, the whole concept of us controlling our destiny and working with what we know for a fact, using that as a starting point and going forward. I believe that the initial definition is not a standard, but it clearly is a starting point. And we have the challenge of creating the standards as we go along with all of the information that other societies have put together, working with them. And at the end of the day, by being small and nimble, we have one chance to get it right, and I believe we are going to get it right. I believe in the people that are involved in this organization, and we have a depth of experience, including Dr. Tony Young's and the rest of the folks here. I believe we're on the right track, and we will get it right. Now we have Mr. Van Green.
Yes.
And could you let us be aware and teach us about digital online reputation management and building consensus and educating folks?
Yes, absolutely. So my name is Ben Breen. I'm the CEO and founder of a company called Canary, and we're a company that focuses on working with individuals to optimize their online reputation. You know, we started Canary really with one fundamental premise, which is that today everyone has a digital footprint. Whether you like it or not, there's a ton of information out there about all of us. Some of it is created by us. Some of it is created because all media now is digital. This just kind of gives you a little bit of the stuff that's actually out there about me. We can say that this is just nice to have, but in reality, that digital footprint really matters. In the past, if you were to do business, you might exchange business cards with someone, and that business card would be a validation of you. You'd say, oh, this is me, I work here, I do this, I'm a doctor. But nowadays, people are going to go online, and what they find online really matters. It will define whether you build and sustain a relationship. In the case of medical profession, it certainly would build and define whether you actually secure a patient of some sort. It also provides a huge validation source for you as a doctor. Certainly people are not going to be looking at one source of information. They're going to be looking at multiple sources of information to see whether you are a credible physician. Certainly people are spending a lot of time online, whether it be using search engines, social networking, or spending time and consuming content online. In the medical profession, when you see 73% of patients using search prior to booking an appointment, I think that is almost like an understatement in showing how important this particular area in digital is for the medical profession. As I mentioned, I'm the founder of a company called Canary, where we build and manage individuals and support them on crafting their online reputation. We work with people to improve their findability online. We strengthen the messaging around what they do or the things that they want to promote. We build and strengthen the bonds to the topics that they want to be associated with, and actually diminish the bonds that they don't necessarily want to be associated with. And in particular, I think listening to the conversation this morning, I think that's particularly kind of an important one to mention. I felt that I was listening to a room of individuals that were debating some really critical issues in your space right now. And you will want to be dimensionalizing the arguments, dimensionalizing the stories that you believe are important for your particular practice in the medical profession. Our technology, we built a platform that essentially pulls all the information together from an individual. We analyze that information to make sure that it's optimized for social, in a social context across social platforms, for search engines and search algorithms, content, as well as strengthening the interests. We literally have a technology that analyzes all of the data and then tells you what you need to do to strengthen that capability. I'm here today, though, really to talk to you about one of the people that we've had the fortune to work with, which is Dr. Richard Kaul. Dr. Kaul and I have gotten to know each other in New York, and certainly we've gotten to be aware of some of the things that have been happening in terms of the New Jersey situation, which seems to be a topic that actually came up quite a bit already this morning. And so Dr. Kaul asked me and Canary to look at his footprint. We saw a lot of stuff about Dr. Kaul out there when we were looking at his digital footprint. There were some tricky things. There was a lot of media coverage, a lot of unflattering media coverage, sensationalist, actually. There's a lot of kind of digital paparazzi stuff, which suddenly, I mean, you guys obviously are important individuals. You're almost celebrities in some cases, and the media loves to find a kind of a paparazzi spin sometimes on stories. There was also kind of on the side of strengthening a story, there was a lot of information about Dr. Kaul as a doctor, but it was very factual, very kind of like, this is where my office is. Not really kind of telling a story, not actually putting an argument together of what actually was happening in the profession. And then all of these things that have exploded in our lives over the last, I would say, 5 to 10 years, whether it be Facebook, Twitter, YouTube, Google+, could be a million others. What happens quite often is that you have individuals that, they create profiles, but they're not necessarily updated on a regular basis. But these are really important. These are really important profiles because they actually link to Google, Bing, the search engines where people spend a lot of time. The information that you place there actually can impact tremendously on what happens with the search engines. And so optimizing those things is actually something that wasn't being done by Dr. Kaul. So we spent a little bit of time doing that. We started to talk to Dr. Kaul in July of this year. Hasn't been that long. Google can be quite tough on folks. There was quite a negative footprint in search at the time. 70% of all the links that were driving traffic to something about Dr. Kaul were negative. You got to also remember that the first half of that Google page pretty much kind of draws almost 98% of all traffic from a search page. So even the fact that even the top links were not owned was significantly challenging. There was really no social media presence as well for him. So our challenges were, how do we build a presence for him? How do we tell a story? Tell the story that this is clearly a space where you guys are debating some fundamental issues of an industry right now. This is quite important to actually tell the story of what you guys are doing. And so is that story being told effectively? Is it being dimensionalized? We worked on that. Certainly there were a lot of, we'd say, kind of unfair, negative things that we wanted to challenge and actually perhaps diminish. And then also dimensionalize the story of Dr. Kaul. While I imagine every one of you is very proud of what we all do in your professions, etc., there are obviously a lot of other things that you're doing in your lives. You are not one-dimensional individuals. And so in the digital context, it's actually very important to tell a broader story about an individual so that you have more control over you. So our process over the last couple of months was that we sat with Dr. Kaul. We have a team of consultants, and they do an interview process. They essentially analyze what the goals are for the client. They look at actually what has been set up in terms of the digital footprint to date. And then they actually provide very, very detailed recommendations. And those detailed recommendations can be quite technical. Some of them are actually very content-focused. We were blessed to work with Dr. Kaul in terms of some of that content creation. And then we go through the process of building out that footprint, building profiles on all of these owned platforms. Because if Dr. Kaul can own these platforms, we can help him own these platforms, and we can help him own the way people are going to find him and find information about him. When we build everything, then we also want to optimize it. So there's a lot of information on how you tag information, how you title information, how you structure content, sentencing, which is, I'm not going to bore you with all of this type of stuff, but that's what our team is, are experts in, and that's what our platform actually analyzes all that content to make sure that it's optimized. So we looked at all of that, we ran everything through that, and then we also added dimensions to the Dr. Kaul story. Obviously there's a lot of things about him, but certainly he's not a one-dimensional individual. There's a lot of other things about his life, and so we wanted to tell those stories, and so we built domain sites to do that. There was also a lot of other information that was flowing. Quite often, we'll see stories, positive or negative, things that you guys may be aware of that tell the story of SASI, etc. They get pushed out, but in reality, actually, they're not really fused into the world of digital appropriately. They are not essentially optimized. And so we were fortunate to work with Dr. Kaul to actually take the information that was coming out about the case and actually connect it, link it into the world of digital communications in a way that actually would support what he was hoping to tell, the story he was trying to tell. Today, if we look at his digital footprint, this is just something that we have. We have a tool called Canary Curate, which is actually a site for individuals that pulls together literally all of the information about you from all over the internet in a visual way. And you can it kind of helps us kind of capture what we were able to do. We were able to highlight Dr. Kaul's efforts in Africa. We were able to highlight his points of view on particular SASI issues. We were able to really bring to life all of the things that he wanted to tell, his story that he wanted to tell. And in 90 days, we find ourselves in a much, much better position. He now has 70% of the links on the first page we call are positive, or we call controlled links. So he manages those links. He is the driver of the way his story is being told. Certainly that is a story that will continue to evolve. The internet is a fluid world, as we all know. So we need to obviously constantly optimize and constantly manage that stuff. But it's a great story of how we've been able to see an individual who he found a lot of other people telling his story for him, and how in 90 days we've been able to shift that back and give him the ability to share his point of view, the way that he wants the minimally invasive spine surgery world to be portrayed.
I know that with the internet, you have people coming to us to help optimize our presence. Like Google, you can pay them to put you first in your search engine. Is there a way for just the average user of the internet to know this is a paid advertising, or this is a paid position, rather than just allow the search engine to randomly get that information?
Yeah, that's a great question. And what I want to clarify to you is actually everything that we do it has nothing to do with paid media. We are all about your natural search results and natural social optimization. So how you look in for I guess, no paid media cost. Paid media costs, when you see a page like this, paid media will be over here to the right? So you have to purchase those keywords. That's kind of, it's a different profession. It's actually something I know while I was a CEO of one of the largest paid search companies for many, many years. But it's not what we focus on.
Does
so
the average viewer know that?
Well, the reality is that the average viewer gravitates to what's on this side of the page, and those are the natural search links. And so those are things that are based on Google's algorithm that you and I don't have, we can't tell Google how to structure that. They're essentially taking all the information that's out there in the world that's in a digital format and giving it a ranking. And that ranking literally changes by the minute in how they're weighting information. So it's constantly shifting. What we do at Canary is that we believe that you as an individual may choose to spend personally more time on one platform, one particular channel over another. Let's say, for example, you might find more value in something like a LinkedIn than you might see in Facebook. You might see Facebook as a total waste of time, right? But what we would tell you to do is to make sure that you have a presence on Facebook, that you own you on Facebook, that you own you on Twitter, that you own you on Quora, so on and so forth. What I mean by that is we don't necessarily advocate that we're telling you to be active on all those platforms, albeit we certainly have guidelines that we would recommend and how you should do those things if you choose to be active in those platforms. When you own those, when you're active in those platforms, what you're essentially doing is you're managing. Imagine that every social platform is a directory. It's like a Yellow Pages, right? You want to make sure that you're listed in every Yellow Pages as effectively as possible. And those Yellow Pages get collected and aggregated to a larger search engine, which is used by everyone in the world, which is predominantly Google. So the only one that I would probably diminish is perhaps Bing. We don't spend a lot of time with Bing. We certainly, certain clients, we do spend a little bit more time with it, but the vast majority of activity really still connects to Google. I'm talking about the fact that people are going to find your information somewhere, okay? And each one of these things connects together to drive what they would find about you on Google.
Let me address a little bit something on there is something called search engine optimization, and that's primarily what affects a lot of physicians' reputation management. And search engine optimization is key to getting it right. The information is there, and once the information is there, is it right or is it wrong? You have an opportunity through SEO to optimize and correct information, at least provide a perspective. You cannot remove information that's put in by somebody else, but you can have a more complete information vis-a-vis what you're doing. As an example, for each and every one of us, maybe in a situation where a patient sues us, or a patient may have making comments about us that's inaccurate. Instead of just attacking that, this SEO gives an opportunity for someone who is just an innocent observer coming in to be able to see you more complete than one perspective. Because for better or for worse, if that person goes unopposed, it will keep rising on the search engine because it's unopposed. And the longer it's there, the harder it is to remove. So that's why a company like this might be very helpful for physicians who don't want to attack an opposing view, but want to present a more comprehensive view.
Yeah, thank you. It's an excellent way of talking about it. I don't mention words like SEO because in reality, it's not just search optimization, but much more kind of your total digital optimization. But the reality is that all of this information, whether it be an article that runs in the New York Times, links together in this world. And many people feel, in fact, that they can't do anything about that. And in fact, they can. They can do quite a bit about how their story is told.
Ben, in the United States, over the last 10 to 15 years, the insurance companies have waged a propaganda war against doctors, portraying them as money grabbers and being greedy, when in fact it's the insurance companies, in my opinion. committing the wrongful acts. And one of the things that I always thought about and I never really saw happen was a concerted effort by physicians to come together to mount their own, quote, communication campaign. And I just wonder whether or not you think, with what's going on with the Affordable Health Care Act, whether the pitch within the medical community has changed so that the doctors are going to come together and start to actually present a cohesive voice. Because, you know, we're within our medical community, I mean, we have these turf wars and these differences of opinion, but we have to stick together, and we have to have a strong communication strategy. And as I was saying earlier, you know, I went to medical school in England, and I saw what happened to the medical profession in the United Kingdom under different Labour and Conservative governments. And one of the things that impressed me when I came to the States was how strong the medical profession in the United States seemed to be. Its position has been significantly weakened over the last 20 years, and I think that a large part of that is just not coming together and having a strong unified voice in the way that the insurance companies have. I mean, they come together and they talk about us and they put stuff out there, and they, you know, they turn the public against us. So, to comment.
I mean, I can only answer it for that type of question, obviously, from my perspective and from the world of digital media. But I mean, I'm assuming obviously bodies such as this can potentially play roles in that story. The reality is that if there is belief that perhaps an industry has shifted and there is a different point of view of how things should be structured and done, what I can tell you today is that there is a way that you can persuasively get that message out in a dimensionalized way using digital media in a much more effective manner. I can't really, I mean, certainly better than the Obamacare's website has been functioning. Yes?
I spent probably 30 years in politics and public affairs. I've never seen a more ineffectual group for influencing public policy than physicians. But there's an inherent conflict between physicians personally and individually and their profession. And I'll give you an example. So personally, you're in the healthcare field. It's in your professional interest to have as many people as possible have access to healthcare. That tends to be a, quote, liberal Democrat sort of everything for everybody. But when it comes to your own personal pocketbook issues, you guys are all a bunch of Republicans. And there's this inherent conflict of acting individually and acting as a group. That's just one example of where I see things break down. So that's all I'll say at that point for now.
I would agree with that, Walter.
Well, the Stark laws are perfect because, you know, at a local level, you're competing oftentimes with other people in your subspecialty, and then the Stark laws prevent you getting together with people that are outside your area. So they got us in a perfect box. I mean, it's perfect. So part of it is, yeah, what you say, but part of it also is the legal entrapment that we've got ourselves in.
I think the problem is we support health care for everyone, but we know that the way the government is doing it cannot work because there's not enough dollars to pay for what we do. And so they're going to be working backwards to try to squeeze every penny out of every piece of work we do. So ultimately, while it is very altruistic to supply health care to everybody, the system, including the lawyers, the regulators, the insurance companies, all the regulations make it impossible for us to deliver. And we know it's going to be a lose-lose situation, which is why most physicians who are individual are going to be against it because we see the handwriting on the wall. The only way to survive, we become not a profession but a trade union, and we work for hospitals. I didn't go into medicine for that. And so, like you said, how do we handle it? Maybe we can't anymore. But we're going to be like England, like Canada, and where are we going to go, to China or something when we need our health care? We know it can't be done financially, at least. At least I don't think so, not with the regulations that we have.
Speak, Steve.
It's being done politically, but the political decisions are not based on true economics. Well, politics and economics don't always go hand in hand unless they're self-serving.
Right. What you promise before the election is not what you get afterwards.
But I think the profession needs a strong communication strategy. It needs, if we're going to hope to survive as a profession, we need to come back together. We need to get ourselves back to that point when it was a strong profession. And the outside force that I'd see as our biggest enemy are the insurance companies. I mean, they really, they have no concern other than money.
The dynamic that's happening that we see is, one of the first questions I always ask a group like this, I didn't ask it today because I already knew the answer. Do you sign paychecks or do you collect paychecks? And in the large meetings, the hands have shifted. Yeah. So the hospitals are buying the physician practices. And guess who's buying the hospitals? The insurance companies. Yeah. And I heard at the not last NAS meeting, but the one before there, the speaker told the surgeons, you're all going to become widgets for WellPoint.
Yeah. It's happening now.
And they have the data. We're in the era of big data, creative destruction of medicine. They got the data, and they know what the data says for populations. We don't yet know perfectly what it does for the individual.
They're economically forcing individual practices out of business. If you can't meet your overhead as an individual practice, doesn't matter how good a physician you are, you're out of practice, and that's what's happening. And it's very specific to say you're out of practice, exactly. You're out of personal business, and where do you go from there? You have to, if you want to practice medicine, you have to be part of a larger organization.
Because if you've noticed with Obamacare, they're not even talking about what physician reimbursement is going to be for these patients. It's not even a topic of discussion, which is they've totally shifted it away from our concerns, our personal concerns, and so we're powerless to do anything about that. So yeah, join up with a bigger group because what you're going to get paid for is completely, and what you do is completely out of your control, and designed to be that way.
As physicians, there's no one organization that serves everyone's interests. The AMA is a joke for us. We don't have, lawyers unions. We don't have lobbyists. We practice, as I say, each independently, hopefully the well-being of our patients. So we're not organized. Without organization and unity, we have no clout, and that's so we get rolled over. And the problem with that is the benefit of the patient. And then if you look at the financial constraints, forcing things back into the hospital is not necessarily the best economic decision to be made. Everything's more expensive.
Here's a soundbite. We're going to put away our stethoscopes and sharpen our calculators to practice medicine.
No, but Walter, that's the point you made, your observation about having worked for 20 years with doctors about the inherent issue. I think it's exemplified in the turf battles that we've been going on, because we all professionally like to feel that we're better at what we do, specifically, in our little operating room somewhere, and we forget the big picture. And whilst we're squabbling over those pieces, these outside interests just come in and divide and conquer. And so in a way, we as a profession have really no one else to blame but ourselves for this situation.
I would also add, it's funny, certainly there are huge dynamics you guys are discussing. Politics, big companies, individual rights, individual business owner rights, individual doctor positions. The reality, though, at the end of the day is that you do need to start with you. You need to start with yourself. And whether you work with a giant insurance group or or not, you know, at the end of the day, when it comes out and it gets discussed in communications, it highlights the individual, you know. And so if you aren't in control of the story, if you're not telling the story, it sounds like you guys do actually have quite a collective viewpoint. But if you're not telling the story the way you want it to be told, you're really going to be in a complex and weakened position. So
that's a great point. I want to echo what Mr. Eisner said, and that is, if you look at the trend over the last maybe 25 to 35 years, and the statistics show that the employment of physician, meaning the guys that writes the checks versus the one that gets the check, the employment ratio has shifted dramatically in the last 10 years. In the state of Washington today, more than 80% of physicians are employed, and more than 90% of surgeons are employed, and more than 95% of spine surgeons are employed. What does that mean? Well, the fascinating thing is that each individual is making a decision as to what's best for themselves as they see it at that point in time, whether they sign a contract, give up their practices, and move on. And the bottom line is the hospitals are in a position that they've never been before to decide your practice, actually what you get to do, what you can or cannot do. There's never been a point in history that hospitals have that kind of control over physician practices. I have a master's in hospital administration. I saw the trend coming years ago where the teaching of the hospital administrators is, in fact, to do whatever it will take to get physicians under the control of the hospital. And it's come very slow, a lot slower than anticipated. At this point, the physicians are enrolled at salaries that are prohibitively high. But it's only for a short term, because once the full control is in place, you know the laws of supply and demand. So what that means for us as a group, and for even bigger groups as NAS, is to understand these dynamics and not get caught up in the little subspecialty battles, and look at the individual physicians and embrace the entrepreneurial physician, but establish standards where medicine is not going to be subject to economic forces that are currently out of its control.
Yeah, and again, I mean, just about telling your story. It's going to be about telling your story. I mean, I don't know if you guys saw this week, it's not a medical journal, but Forbes now is up for sale, and announced it this week. Forbes, I mean, Forbes is probably one of the preeminent business publications that has been part of our lives for forever. And they're essentially now not able to sustain that business, because the idea that the media controls the message is gone. You guys control the message. You just need to do it, right? And be empowered to make it happen.
So I'm a little distressed by the message you were just sending. I mean, I'm employed at a hospital. I work at the University of New Mexico. I feel like I'm doing good work. I feel like I'm trying to do the right thing for patients. I feel like I'm trying to drive our practices within the hospital to do the best thing with the resources we have available. And it sounds like you're kind of saying that I may be doing the wrong thing for working with a hospital. So can you talk to me about that?
Yes, you're not doing the wrong thing at all. There is a difference between the discussing the bigger picture, the economic flux, the movement of physicians from being writing checks to getting checks. That's an economic issue that has nothing to do with your devotion to the practice of medicine. You will and should continue to be the best doctor you can, no matter where you work. We're talking about a much bigger picture than that.
But I'm going to echo back to you again that if it is a bigger picture than that, and you think that it depends entirely on physician independence, then that is, I think that's a message that cannot coexist unless we redefine it.
Well, I think at a level, a physician has to be accountable for his actions and his practices. Unfortunately, the guidelines of how you practice medicine is being controlled on a daily basis by hospital policies. You don't decide on what tools you use anymore. You don't decide on who is in your operating room anymore. You don't decide on your work hours. These are things that have traditionally been under the control of a physician, as an example.
I mean, I'm not sure I agree with all of the statements you just made. I understand that I have less control as someone who works as a part of this hospital than I would have if I were an independent entrepreneurial physician. But the hospital has board meetings, the hospital has ways for the physicians to participate, and that does not mean that I have the same degree of freedom. But what it does mean is that I do continually have a force within my hospital, a communication with which I can communicate best practices, and I still have the ability to leave if I don't think it's been appropriately conducted. This is something that is my choice in the end. But again, if you keep on framing it as this is something that if physicians are not making all these decisions, then the right decisions are not being made, I don't think I can agree with that.
Yeah, you are entitled to your opinion. I am looking at it not from a one hospital point of view. These are things that are well observed, well written, and established in the literature and also in the community of states. So you have to go from state to state to get a bigger picture of what I'm talking about.
So then, to be clear about this, if I work in a hospital practice, I am actively contributing to the destruction of physician freedom to practice.
Not to say that. What we're saying is that hospitals in general, and like I said, I could be a CEO of a hospital if I chose to. I chose not to do that. Well, hospitals in general have a general approach to controlling physician practices, no doubt about it. Okay, you are saying you have better control at your facility. I congratulate you. Not many physicians can say that. So you are an exception to what the big trend possibly looks like, and this is a fact.
So then,
can I say something? Let me just say something. You're a rare breed. Most physicians go into medicine because they want to be an independent physician. And it sounds like you have a passion to do what you do and continue to do it. And it has no negative impact on what we like to do. But as I said, you're rare. Most physicians want to practice independently and make their own decision independently. That's where it comes down to. So it's nothing that you're, but if the whole world decided, the whole United States, the whole world decided to just hire physicians, that's not what we're all about. Probably 99% of physicians want to work on their own. And the majority of physicians that are in your position don't want to be there. And I compliment you, the fact that you want to be there and you're protecting it and continue to do it. But overall, as I said, we want to be independent. And that's what it comes down to.
And so that's the reason why I called this out, is because I just want to make sure that there is not an animosity between those of us who are actually trying to move the profession forward within the practice pattern that we feel passionate about. I do not think that it is appropriate for hospitals to be restricting the practice of people practicing in the community according to their best judgment. That is appropriate. But I mean, you know, if you say that hospitals are destroying all of this, and I work for a hospital, I mean, what do you expect me to say?
Can I just say, again, one of the main reasons that I moved from the United Kingdom to the US, other than the fact I met an American girl in London, was the fact that I did not want to work in the National Health Service because of what had happened to healthcare in the United Kingdom. It had become completely politicized, and doctors were just paid lip service by whichever government was in power. And I don't know if that same thing is going to happen here, but it definitely should be a concern of the profession, and I think also with the medical profession in the US, I think the demographic change, there's more women coming into the profession. And I think if things continue the way they are, I think 5 to 10 years from now, it'll be a predominantly female profession.
I'd like to ask the physicians in the room a question, and I think it goes to your organizing principles as a society and what it is you're hoping to accomplish, because ultimately you have to answer to the payers. So how many physicians in this room believe it's their job to control costs? So 1, 2, 3, 4, 5, 6. Well, you guys are outliers. Physicians, according to a recent study done by the Mayo Clinic, say, ain't my job. My job is to deal with one individual patient and whatever it takes. And it's the lawyers and the insurance companies' jobs to control costs. If you want to make the case in your credentialing, in your standards, that those standards that you put forward will save money because it's cheaper than some of the other things, you may want to think about having that be an important part of your mission in controlling costs, because the payers will like hearing that. And it goes back to Dr. Kaul's question about, or my comment about physicians being so ineffectual. When the big public policy issue is, why are we paying twice as much and getting no better results than everybody else in the world? And you guys go, hey, it ain't my job. Nobody's going to give a rat's ass what you think about public policy if that's the starting point. So I think you got to weigh that.
We have in fact addressed that in our board meetings as a key point of why we exist, why we want to get this out, and that is we want to be case managers on cases and on the individual patient level, as well as our own patient population, making sure that we are below the radar as much as possible and containing costs just like we would in any situation that we're involved with, either in our surgery centers or the hospital. And I think with doctors that work inside the hospital with this level of commitment that our young doctor has expressed, I think he will be an exception again, contrary to the statistics that we know about physicians not wanting to control costs. I'm sure he will be more conscious of it, and the hospitals, in fact, might reward him accordingly.
Excuse me.
For the
excuse
record.
me. There's also physicians in this room that have done charity, have gone overseas, have, like the Spine Africa Project, they have done things just for the care of the patient. It was no concern about how much they were going to be paid, what they were going to be paid. It was more about help. And I'm sure there's other doctors in this room that I don't know that have done the same thing. So again, controlling the costs is nice. At the same time, things have gone to the other side where they've gone out of their way just to help. So, I mean, that can't be minimized either. Thank you.
For the record, Dr. Evans' involvement is not as a hospital paid employee or administrator trying to control doctors. He's an educator. He happens to take taxpayer money to do that. He's happy to be in that position, and he is helping set the standards for what is appropriate training for those of us who are.
Excuse me, we're addressing the word standards again. We've had this discussion off the record and on the record. Standards change. They're a constantly evolutionary process. So to talk about standards, you want to talk about guidelines, we can talk about that. We want to talk about policies that are in place right now, we can talk about that too. But if you want to talk about standards, standards are constantly changing. It's a fluctuating body. I mean, the best buggy back in the day was a standard. Now you have a car. Then the cars are changing. Pretty soon the car is going to be driving itself. The standards are constantly changing. So I have a problem with the word standard, but if you want to talk about guidelines, I can appreciate that. Thank you.
All right. I'm not a lawyer, so I won't use legal terms. But what I'm interested in is education of doctors
to do what's best for their patients safely and efficiently. And it has to start somewhere. It can't be individuals, even including myself. Somebody has to reference that, do the studies, power the studies, and do what we're all striving to do, is have evidence-based medicine to validate what we're doing. And we are not
I
good enough to do it as
I
an
don't see any
individual.
disagreement. What we were talking about was cost
So
containment.
I won't use the word standard.
Good, thank you.
Okay. Thank you very much. Again, if it was easy, everybody would be doing it. These are very tough questions that have so far eluded even the most respectable societies out there. We are happy to take on these questions and literally address them. We're not afraid. So we are happy that it's all coming out. And before I leave the question of hospital versus small facilities, the latest in terms of outcomes specific to spine came out earlier this year, I think sometime in August or maybe early part of the summer, where it was shown unequivocally that it is safer to have surgery performed in a surgery center than in a hospital. So this is very important in Spine magazine, the Spine journal. Please refer to that, okay? There is a reason why. The reason is individuals that are involved in surgery centers are equally as committed, but they don't have all the ramifications and all the things that go in the hospitals to hold back their outcomes. So it is safer. If I was going to have surgery, I would have it in a surgery center, not in a hospital. Because statistically, level 1 result shows that's the best place to do it. Thank you.
I'm sorry. You know, if you state it that way, it seems as though you're trying to push hospital practice physicians out of the society. If that's what you want, then go ahead with this line of talk. If you want me to participate, say, hey, maybe we can work together to improve standards for hospitals, and then we can work together. But if you keep on pushing it that way, you are actively trying to exclude me as a participant from the society.
That's just a fact.
I am not. I am letting you be aware of the literature.
I'm aware of the literature, thank you. I mean, I also am a participant in the literature.
I welcome everybody open-handed.
Well, then let's start the discussion that way. I mean, if we have surgeons here, if we have interventionalists, if we have PM&R doctors, if we have lawyers and representatives of these societies that are trying to represent physician interests, why are you trying to push a specific practice model? Because that's really what I hear. Maybe you can clarify and help me understand what it is you're trying to say.
Yes, I'll clarify again. We're not trying to pick on any group at all, quite the contrary. We're trying to lay out the raw skin, lay out the facts, and work together.
I think the problem here also is the fact that they've taken some very good procedures out of the surgery centers and force you to do it into the hospital. That is nothing against you personally, but we're kind of offended by that, and it's affecting our practice, and it's affecting the care of the patients. You know, there's certain hospitals, I don't know how your hospital runs, but I was forced, like the mafia, to do procedures in the hospital for me to maintain my credentials in the hospital, privileges, forced me to do it, or they're going to throw me out. I did 3 epidurals, or 3 transforaminals, I think 1 radiofrequency. It took me 4.5 hours to get out of there. I do that in 45 minutes in my surgery center. This is what it comes down to. It's nothing against you personally. This is our experience. And what he's stating is nothing against you personally. It's just fact, statistics, studies. That's it. But you're welcome to join us.
Again, I mean, I'm here because I'm interested, and I think you got to do this kind of thing right. We can work together to move things in a direction that's going to improve patient care, and I think if you keep it like that, that's fine. But if you tell me that the hospital-based practice is the wrong thing to do because physicians aren't in every step of the decision-making process, I mean, it's hard for me to want to work with somebody who's telling me that I'm doing something that cannot be right.
Wait, one more thing. Another thing is we need somebody like you to keep us in check. All right? So this way we don't discriminate. And we don't personally discriminate against you or physicians. Yeah, but keep us in check.
Let's move on. Richard, can you please come forward and make your presentation? Appreciate it.
Thank you. I had put together a presentation which I was going to give, but after having heard everyone talk this morning, it's changed, it's metamorphosized into something that it wasn't at the beginning. Can you hear me? So the title of the talk was "Where Does the Future of Spine Surgery Lie?" And I had it as a global vision. And I'm just going to talk a little bit about the turf wars that have been going on, and a little bit about the situation that I've just gone through. And in the obvious answer to the question, where does the future of spine surgery lie? I mean, we just really have to look at what's gone before us. And I always use the example of cardiology, and I say 20 years ago, the cardiac surgeons were performing most of the procedures that were required to fix people's heart problems, and the interventional cardiologists came in, and they came in initially with just stents, but the scope of their practice has significantly widened over the years, and now they're placing valves, and they're doing all kinds of things to the heart. So, I've been listening to things that everyone has said this morning, and when Tony first started talking about the line with the issue of fusions and interbody implants, I think that that's going to happen within the field of interventional radiology and interventional pain. And I say, just again, look at the example of cardiology. As I mentioned earlier, I first came, went to medical school in London. I first came to the States in 1989. And, I love America, I love being here. And one of the things that I always looked up to and attracted me to this country was the innovation in the United States. And that sense of innovation that, as I was going through medical school in England, seemed to have been lost. It wasn't there. So when I came to the States, there was a lot of progress being made. And I think in the field of spine, when we look at the United States on a global platform, and we look at the changes and what's been done here, the country has positioned itself very well compared to the Asian bloc, particularly to the European bloc. But I think that it also stands or runs the risk of going the same way that the United Kingdom has gone in terms of innovation if it doesn't get its act together. And there's a lot of forces acting internally that are working against innovation. The FDA makes things very difficult. The insurance companies make things very difficult. The excessive medical malpractice situation in this country makes things very difficult. And so I think if America wants to stay relevant, sort of in a spinal geopolitical framework, these issues need to be looked at internally. Because if they're not, what's going to happen, in my opinion, is that doctors who are graduating from medical schools in India, Africa, they're not going to be necessarily looking to come to the US anymore for their training, because they're going to see where innovation and development is moving. And also, secondarily, from a business standpoint, I think that, and particularly now in light of the Affordable Health Care Act, patients themselves are going to be shopping globally. They're not going to say, well, we're going to use, particularly if you've got elective procedures, they're going to be looking to go overseas and looking to Central and South American countries. And I say that based upon again, my experience and knowledge of what happened in the United Kingdom with patients who started to go out to India. private Indian healthcare companies very aggressively went out and marketed their services to Europe, to the United Kingdom, and they pulled a significant amount of work away from the UK to India. So I think it's important that we as physicians in the US, that we come together, that these internal battles that we've had and continue to have, that we try and understand that it's for all of our good if we can find common solutions. Another thing that I heard and seemed to become a hot topic was this issue of hospitals and ambulatory surgical centers. And that's another element of what's gone on and what's been one of the forces behind this current battle in spine, and particularly in the state of New Jersey, which is where a lot of us are from. A year and a half ago, 2 years ago, the state enacted legislation which said that particularly the auto insurance carriers were not going to pay for interventional pain and minimally invasive spine procedures in a surgical setting. They had to be done in a hospital, which made absolutely no sense. I mean, the clinical arguments for having cases done in an ASC, from the infection rate to the cost, to the ability to get patients in and out in a more expedient fashion, were very strong. But the hospitals have lobbied aggressively, both on a state level and on a federal level. And I think that the point that was brought up before about just being aware of that is relevant to the experience that we've had in New Jersey. And then I'm going to talk about reputation and what Bant had talked about before, and how we as physicians, when we're attacked, whether it's by an insurance company, whether it's by a patient who's bringing a medical malpractice lawsuit, when they attack us and they post comments online and they come after us, traditionally doctors have never really done anything. They've been too busy practicing medicine, and it's generally not in a physician's nature to stand up and make that kind of fight. But I can tell you from my own personal experience, when my license was suspended in April 2012, the state of New Jersey did me a favor by taking the case into the public domain and publicizing it widely. And in my view, there was no need to do that, but it was just an attempt to attack my reputation. And that's when I came to the realization that I was going to win this case actually in the court of public opinion. And that was when I started to recognize that my online digital profile was terrible and that I needed to pay attention to that. And I think that as a profession, that's something that we need to give more focus to. Every other industry does it. They have slick marketing campaigns. They've got, they have public relations committees. And we as doctors, because we've been so fragmented, we haven't been able to come together and present that cohesive front. And I think we should. Let me just come back to the question, where does the future of spine surgery lie? It lies, in my opinion, in an outpatient setting. It lies, in my opinion, with doctors who come from backgrounds of interventional pain, interventional radiology, neurosurgery, and orthopedic spine surgery. And it lies, in my opinion, on a global stage. There are global markets that are developing, India, Africa, South America. And I think from a business perspective, doctors in the United States who are looking at their paychecks and their businesses shrinking should consider looking at opportunities in emerging markets around the world. That's it. That's all I have to say.
Richard, I have been educating physicians all over the world, pain management, doctors. I'm fearful of who I train because some of the techniques that I bring to an undeveloped country, they are used by people who I think are not really qualified to do it, and they are operating on people who are not very well educated, who don't want surgery, so they go through these interventions. I had one interventional specialist from India was so proud of his work that he was showing me, wanted to show me his videos, and he was pulling out nerves, and he had no idea what he was taking out. So that's what makes me concerned, because I don't want what we have spent promoting to be put in the wrong hands. And so with your hands, great. Steve Levine, great. Gabe Jasper, great. But can you say that for the majority of the people, you know, in that category? So that's why we have to have certain guidelines. And we're willing to teach, but we have to have some control over what happens after we teach the technique.
I also want to make sure that information is correct. I'm very, very keen on precise information.
When I talk, it's what I've experienced, actually experienced. I've been around, I'm 71, none of you are my age. So at least I should have a little respect for my experience. I'm supporting you, but I'm saying guidelines, do it in a way that you don't discredit yourself by teaching too many people.
Yes, and because of your experience and age, we're also going to forgive some of the misinformation that you also included. I am also a teacher in China.
Prove me wrong.
No, I'm not trying to do that. I'm just trying to correct information. I'm also a teacher in China. I have a professorship at one of the universities. I've taught neurosurgeons, orthopedic surgeons, and also very few actually pain management people. And the truth of the matter is that they are bad surgeons and they're good surgeons. And it has nothing to do with specialty, has more to do with the actual training.
The fact that you're from the United States puts you at a different level, although already in the eyes of the Chinese.
You were saying, it was almost like you were saying innovation equals income. And you know, that's sort of what I was getting a little bit out of your talk, which I think you can be innovative and make the same money.
Yeah, everyone realizes that you know, economics and healthcare, they're bed partners, right? I mean, money. You need money to pay for healthcare. Innovation is important.
Technical innovation, you know, medical innovation. Because what I was hearing, I wasn't clear about what you were talking. It's almost like we're coming up with an innovative business model, or were we coming up with an innovative way of treating backs, or what
yeah, I think what you're referring to, my comments about understanding a global healthcare platform, and I think that you know, other doctors from other countries have recognized that and have made inroads into that. And I use the example of Indian physicians, and I use a number of very large healthcare corporations in India. For example, there's a hospital in Calcutta. They do a huge amount of cardiac procedures. Right. They went to the National Health Service in London.
So you're talking about innovative business model, I guess, is what you're talking about, not so much innovation. I just wanted to be clear, because it just seemed like they were kind of intertwined, and they're different, right?
Well, yeah, I mean, innovation, I mean, in both technology and techniques, and of course innovation in the business model. Those are both good things.
But see, sometimes when you don't have those two things separate in your own mind, then that's a little bit of a situation where that you have to get clear.
No, I'm not saying at all that a patient's interest is subjugated to the physician's economic interest. That's not what I'm saying or what I did say. What I meant with the words that I used was that as circumstances change, as they are changing here in the United States, that physicians here, I would think, would want to look to opportunities as to how they can, particularly if they're younger physicians, as to how they can develop and build their practices on a global platform. Yeah, because that's what physicians from other countries are doing. That's absolutely what they're doing.
Which is different coming up with the new endoscope. Okay.
Yeah.
It wasn't clear what you're referring to.
Yeah. Okay.
Dr. Jasper.
I was asked to prepare something for this meeting, and the preparation was about the foraminal view, basically the evolution of endoscopic discectomy, and that's my opinion on what I think this topic is about. We started, I feel very fortunate that I started as one of the pioneers, of course not like Tony Young and a lot of the other guys, but I started right when it started to change. The evolution started to change big time. When we started with the inside-out technique, the outside-in technique, and strictly outside, intralaminar, strictly inside. I mean, there's a lot of terminology how we did this, but we've all evolved. In the beginning, and I use I have used different slides from different professors. You recognize this is from Tony. But Tony taught me how to do it like this, and it was great. It worked fantastically. And I thought it was the best thing. But then we got to the point where a lot of the patients who had a herniated disc or an extrusion, a small extrusion, they did very well. But then we had to worry about the neuroforaminal stenosis, and that's basically what I like to talk about. It worked good with the strictly inside technique worked great for little herniated discs, maybe little extrusions, but for large extrusions, sequestrations, foraminal stenosis, it didn't work that well. And this is what we had to deal with. We had to deal with the foraminal stenosis from hypertrophy of the facet joints, and also the end plates, osteophytic ridging, spondylolisthesis, and endoscopically over the years on the evolution, we were able to, at least I learned from other physicians, other surgeons, and developing my own technique with cadavers on how to safely take off the end plates and just open up the neuroforamina on patients with these severe foraminal stenosis, and also to a certain extent central stenosis. We're able to get off part of the end plate, SAP, just making enough room so the nerve could live in there. A lot of times you have patients that have major surgery and they have spinal cord stimulators with failed backs. And if you know how to read the MRIs and the CAT scans, you can see that most of the time they fuse them, they do laminectomies, and if you look at it, the patient still has a herniated disc, they have foraminal stenosis, and they have a spinal cord stimulator in them. A lot of times I take the spinal cord stimulator, I get a good MRI, and look at what the actual pain generators are, go in there endoscopically, take it out, and the pain goes away, and they come off of the pain medications. This is the evolution of where we're coming today and in the future. Here, I found this slide. This is a very good slide with the hypertrophy of the facet joints. You got the herniated discs, your ligamentum flavum. This can't be done by just going inside the disc and taking out a herniation, which we all used to do years ago. Ligamentum flavum, we're working on techniques now, minimally invasively, to go in there under direct visualization to take out the ligamentum flavum. I mean, that would be the ultimate goal. I don't know who's doing it now. I've dabbled in a little bit, it's worked, but we're lacking instruments to do this, efficient instruments to actually do this. They have the Miles technique, which, statistically, some studies say it works. I like to do things under direct visualization. So this is the future, and we haven't mastered this yet. To go in there even intralaminarly and take down the ligamentum flavum in a short period of time without creating scar tissue and relieving the pressure of the center of the canal. I would love to do something like this with the right instruments. Since we talked about neuroforaminal stenosis, I majored in art in college. So I try to make my patients understand exactly what we're going to do. And I drew these pictures to to explain to the patient what we're going to do, and they understand exactly what we're doing at this point. I tell them that this is their problem. They have stenosis, have a herniated disc, bone spurs from the facet joints, and I explain to them we go in there endoscopically with a small incision. We directly visualize the herniation. We put in our instruments and actually show them the instrument in my office, and then once we do that, the herniation is gone. And then we start taking down the facet joint with bone spurs, and I show them how the nerve is irritated, how the herniation came off, and now the nerve feels good at that point. This is all basic stuff, but this is how I explain it to my patient. And once we do that, the nerve is free. You hate to say cure, but at that level, where we freed the nerve, they're not going to have any pain there, at least not for the near future. And I explained to them, they say, is this permanent forever? I said, no. If you get more degenerative disc disease, you re-herniate, you get more hypertrophy of facet joint, it could come back. But the fact is, you're just going in there with a very small incision, and you can take it out, again, 5-6 years down the road without any major surgery. And I just have one case study that I did last week, actually. It was a 77-year-old lady who had severe foraminal stenosis at just about every level. And as Tony Young was talking about, you have to be able to do these nerve blocks, and that's one of the reasons why Dr. Young has learned how to do these nerve blocks, because this patient was my patient probably seven months, and I gave her a few injections, and based on the history of her transforaminal selective nerve root blocks, I came to the conclusion that most of her pain was at 4-5 and 5S1, even though 3-4 was very stenotic. I brought her in and I did a foraminotomy at those two levels. This is 4-5 on her right side. I did a foraminotomy and took down the herniated disc. We don't have the video's not going to come up. Anyway, the patient had no more pain post-operatively. She was walking. She could barely walk preoperatively, and post-operatively she walked very, very, very well. This is actually intraoperative shots. At this point, you can see that she had central canal stenosis, and she had hypertrophy. The ligament wasn't that bad, but she had some osteophytic ridges, and I took down some of the osteophytic ridges. And you can see that I can come across, after taking down some of the end plate and taking down some of the SAP, I can come in with the cannula and actually go past midline, which I'm sure a lot of surgeons can do that are here now. And this is the evolution. We weren't able to do this 5-10 years ago in order to make these patients feel better. And I also want to emphasize that we need to do some publications in some reputable journals. This is one of my studies I did, and I went into the clinical neurology and neurosurgery, and I have 195 patients with 321. This is when Medicare was actually paying for some of it. What I would do is, if a patient had 4 or 5 levels that were bad, I would pick, by doing selective nerve root blocks, the worst levels, and I got very good results doing maybe 1 level at a time or 2 levels at a time, to the point where we had a pretty high success rate. This is my success rate here. Excellent, good, fair. So it was 93.8% success rate in this study. And then I did some case studies in different journals. It is total so far 4 were published, and in Pain Physician, and I got future studies on. Right now, I'm working on a study with spondylolisthesis, and it works pretty good because of the fact that we can work now in the neuroforamina. We can open up, we see the nerve, we can free the nerve from even the end plates. But future studies. We're doing some studies on intralaminar approaches for, let's say, L5S1 without foraminal stenosis with centrally located discs. 15 minutes, you take it out. It's kind of like a glorified microdiscectomy, but it's a very small incision. You go in, you come out. Sequential dilators. You're not destroying any tissues. And there's also the approach where I have, by doing myelograms, you could see where the dura is, and you can see the defect. And if you have some of the herniation that's on the contralateral side, you can come in contralaterally through X-ray, lateral X-ray, AP X-ray. You can easily go past the dura without injuring or penetrating the dura and make it behind the facet joint and take out a central, paracentral herniated disc that's also behind the pedicle. And we're also doing it in obese patients. We're going to do a comparative study. And also, I've done quite a few unstable spines. Of course, not severely unstable spines, but patients that flexion extensions are considered unstable, don't want surgery. They don't want traditional open surgery with fusion. And I've gone in there and I free the nerve and I leave enough room so that when they do the extension flexion, it's not putting pressure on the nerves, the traversing or the exiting nerve root, and they do well. You know, how long it's going to last, we have to see the future. And that's it. So the basic thing is, like I said, I feel fortunate to start doing the basic intradiscal technique and advancing through following my peers and the surgeons that were better than me to learn how to work on the neuroforamen and relieve pressure off of the nerves. And that's it. Thank you very much. Any questions?
So Gabe, the first one to do this was Martin Knight with the Holmium YAG laser in 1993 after he took the laser course. And I started doing it about 1996 after I visited Martin Knight. But I didn't want to use the laser because at that time, if you say laser, all of a sudden you're dead meat with, you know, the surgeons. So while he continued, he even is prosecuted in London because of the laser, but he never changed. But as we developed instruments to allow us to do foraminoplasty, I slowly did that in 1995 and 97, and I didn't even talk about that until I could prove that I had good results. So you're right on, okay? So you're doing it, you independently developed this, having heard from others, but it's hard to accept the fact that maybe not everybody learned from someone who has developed the technique independently. So you independently developed it. When I talk about inside-out technique, that's just to get you started. But we know that not everything is inside out, and I deviate from Camden when he said, stay out of the canal. I wanted to see, in 1991, I wanted to see the epidural space. And I was persona non grata with Camden because, you know, it was different. So from a historical perspective, I lived all that. So let's just congratulate each one of us for developing it. You're right on.
Absolutely.
Okay, but it depends on the development of instrumentation, and as we developed it, we make it easier and safer for all to do. Now we have burrs, we have articulating burrs, we have lasers, and ultimately, when you get in trouble, go and use the laser, but don't use it for the whole procedure.
Yeah.
So we're going in the right direction. Just wanted to make sure that the historical perspective is provided. Even in neurosurgery, Harvey Cushing was given lots of credit for everything, but it wasn't just him. It was somebody in Hungary, and they did together. He just published it first.
It's amazing. I see, as I've developed my technique, I look back, I say, you know, I hope everybody else is doing this. And you look back, you see some of the videos, you talk, like I speak to you, I speak to the other surgeons in Europe. Everybody's evolving almost simultaneously together because, you know, we stick together. Right. And it's just the evolution, with, like you said, with learning the anatomy, learning what's on the other side, learning how far you can and cannot go, being able to see what you visualize three-dimensionally on a two-dimensional picture.
Well, the mistake I may have made was limit interventional pain management to simple procedures before you advance. You happen to advance faster than anybody else, like Steve Levine. Okay? But it's an evolution that we all should be proud of contributing to.
I agree. Thank you.
Can I open up an old wound here? Can I talk to you guys for a second about fusions? I just want to get an idea of who we have here. I know that we have Dr. Young, an orthopedic surgeon. Dr. Harrington here is a neurosurgeon. Do we have any other surgeons in the room? Is that our entire surgical representation? How many?
Not that many people here, period.
Yeah, sure. So how many of us are anesthesiologists? 1, 2, 3, or so. And how many of us are physiatrists? Physiatrists. And how many lawyers? Got a couple lawyers. How many society reps? How many company reps do we have? At least one. A couple back behind me I haven't met yet. How many people think that neurosurgeons and anesthesiologists are equally qualified to perform trigger point injections? How many people think that both surgeons and interventional whoever's are equally qualified to perform trigger point injections?
Absolutely.
You think that a surgeon can understand the pathoanatomy of muscle pain enough to put some anesthetic in the muscle?
Retarded, but if they have a pretty good brain, they might.
So I think that's reasonable. And then epidural steroid injections, you'd say the same thing. A retarded neurosurgeon probably shouldn't be doing it, but in general.
You will never hear me say that a doctor, physician, or surgeon, or whatever in this country is unable to do something. Mm-hmm. I've seen neuro spine surgeons do perfect transfemoral epidurals, better than a lot of interventional pain physicians, and vice versa. I teach orthopedic spine. I teach interventional pain, neuro spine surgeons, and it's depending on who's learning. Some people have better hands than others. Maybe initially the orthopedic spine surgeon has a pretty good idea of working the scope because they do a lot of arthroscopy compared to a neurospine surgeon. But if the guy's good, he's got good hands, he's going to learn it quick to a certain point. It's always a very shallow learning curve when you're learning endoscopic discectomy, but you can't. And I think that they should all learn, and maybe some of the other anesthesiologists don't agree with me, I think anybody doing spine surgery should know how to do selective nerve root blocks. I mean, when I do I don't do discographies anymore. All right, maybe discogenic pain, but you can know when the person's going to have discogenic pain. You see the tear. If you have 4 of them that are torn, you want to get the worst one and treat that. All right, you do a discography. But when somebody has foraminal stenosis, big extrusions, you don't need to do discographies. What you do is you treat them. If a surgeon has a patient coming in because they got pain, orthopedic neurospine surgeon, and they can do a selective nerve root block, a transfemoral epidural, and they can narrow down a 5-level bad disease, narrow down to 2 levels or 1 level, they know what to operate on.
So I totally agree with you. We need to be training our spine surgeons better, right?
Well, no, they're learning on their own. They're learning on their own. They know the value of being able to do a selective nerve root block. I mean, if you have somebody, you want to know whether is it the traversing nerve root of L5 or is it the exiting nerve root of L4-5. You do a selective nerve root block, boom, you know what it is.
Totally agree with you.
And but what you're speaking to, everybody should have.
Right.
Everybody should know how to.
What you're speaking to is this concept of spinology. That there should be a lot of overlapping skill sets, a lot of overlapping diagnostic abilities, your ability to put together a clinical picture to choose an appropriate treatment plan. Right.
The old days. Well, it's not the old days because they're still going on a lot. Surgeons, sending patients to a interventional pain physician, say do some epidurals. A lot of them have ulterior motives. It's going to fail and come back. But some of the smart ones that understand the concept say, listen, can you do me a favor? Let's try to isolate which one's the worst level. Do a selective nerve root block here. Communicate with me. Talk. If they don't want to learn how to do the transferembols, they don't want to learn how to do the selective nerve root blocks, you can have that rapport. But if you don't have that rapport, then I think the spine surgeons it's a good idea to learn how to do that. The traditional open spine surgeons.
Absolutely.
Learn how to do these transferembols and selective nerve root blocks.
So then you get discectomies. That's kind of an extension of the intradiscal procedures, and then you start to look at the foraminotomies. Yeah, sure. Your disc decompression procedures, your IDATs, your biacuplasties, and then from there you just put a scope in and say I'm using a surgical tool to do the same thing I was doing interventionally.
No.
And
you
then
have to have the indications. The indications.
Oh,
if you
of
have
course.
somebody,
Indication
if you have somebody with a
so hold on just a second. I'm not arguing indication. Yeah. You have to have a good candidate first. You're not just doing discectomies for discectomy's sake. Okay, so if you've got an appropriate patient, an appropriately trained person, you'd say that a surgeon or an interventional person would be equally qualified to put a needle in the disc or a scope in the disc, right?
Why not?
Totally agree with you.
As long as they have the proper training.
So then, from that point, if you say you can do that, you're doing your foraminotomies. That seems appropriate because you have to get into the same space, and then you go to your fusion. Is it okay to do a single level fusion for the appropriate indication? What's the appropriate indication? Do it minimally invasively.
Well, first of all, you're talking to a person who does not like fusions. I just said it. I see up to 30, 35, 40 patients a day. And in a 2-year period, I sent out only one for fusion. And you know, I might be the extreme, but I mean, you see what I'm pointing out, and it was a quick discussion, but when I go in there endoscopically and I see somebody has an anterior retrolithiasis with foraminal stenosis caused by hypertrophy of the facet joint, whatever, not much disc left, but most of the disc is on the outside, putting pressure on the nerve, and then you got the end plate, which is pressing on the nerve. You go in there, you can see the nerve, you decompress it completely, then you don't need a fusion. The patient's pain is gone. Most of them are elderly.
Because you open up the frame and
Because you open up the frame, the nerve now is floating in there, the traversing nerve.
Sure.
Nerve pain is very different than back.
Totally.
Once the nerve's decompressed, the pain is gone instantly.
Right.
If it's a trenic and there's weakness, right? It's
Right.
an instant outcome.
Right.
It just goes away. So if you have to fuse.
So I'm not asking for an indication. I'm just asking about your idea of what the appropriateness of fusion from a minimally invasive point of view is, because this is something that was really interesting to me as we were discussing it. It sounds like from some of the camp, it's saying that fusion is appropriate if you can do it technically adequately. And then I'm going to take it to the next step here.
Let me answer that question before you go ahead. What Tony said, he doesn't do fusions.
Mm-hmm.
Right? I don't do fusions. I have no intention on doing fusions because I don't believe anybody really needs a fusion. Right? So wait a minute, wait a minute. If I send out, and I think I'm pretty good at it, and my patients do very well. If I send, no offense to you, Richard, but if I send out one patient every 2 years for a fusion, I don't think I'll ever get good enough to do a fusion. I'm going to do one every 2 years. I'm not going to be good enough. So I'm going to send it, like Tony says, send it to somebody who does a lot of fusions, like Richard. You know, he's great at doing percutaneous fusions. I'll send them to him.
So then here comes my next step, to take it from a single level degenerative segment that's probably, you know, not terribly unstable. I mean, how much deformity do you think it's okay for a percutaneously performed fusion or an interventionally trained physician to try to correct?
Endoscopically?
Well, you know, minimally invasively, interventional trained, interventional radiologists, anesthesiologists.
To answer that question is, the sky's the limit based on your experience. I mean, I've been doing this for close to 10 years, or maybe 10 years now, and I've been doing foraminotomies, foraminoplasty now, probably for over 5 years, and I could just about open up anything. You know, it takes time. You got to be tedious. You got to know. But I want to. Somebody I'm teaching who's been doing endoscopic discectomy for a year and has done maybe 200. I wouldn't even attempt it.
So
it's based on your experience.
So from a societal point of view, if this is supposed to be kind of directing.
There is no difference in the indication or procedure that the whole committee of physicians agree upon. There is no difference in indication for fusion, whether you can do it invasively or not. You either have the appropriate pathology that justifies the procedure. The approach is a different matter.
So then my question is just to extend it to the next step. So now you've got multi-level fusions that you say it's okay. You're correcting large orthopedic deformities if you can across, you know, lumbar and thoracic and perhaps even cervical segments. Is that something that you could?
The proponents of minimally invasive spine surgery that do multi-levels are actually open spine surgery. So if you're questioning the terminology, that's a different story.
I am questioning the terminology. I think we need to be very, very clear. If you're going to talk about fusion or something like that, you need to be very clear about what you think is an appropriate thing for your society to represent.
And we appreciate that. And that's why we're having these sort of meetings to come together and be very clear as we communicate to the community of physicians about what we're about or what we do. We're not redefining indications. We're simply defining tools and techniques that will minimize collateral tissue damage.
Kevin, what's your point?
Point is,
Devil's advocate, I like that.
No, if you are going to say that, you know, there are interventionally trained people who can adequately perform fusions, and the success rate seems to pan out, you know, where are you going to draw the line? Are you going to say, you know what, it's a little bit strange to...
I think the questions you're asking are not answerable. You're asking for limits to be hypothetically. I mean, you know, a physician sees a doctor, evaluates the patient's condition, and makes a decision as to how to treat that person. So you're trying to, you know, you're being a bit bureaucratic, I think. You're trying to put limits on, you know, what can and can't be done. And each physician is different, and each patient is different. And so, you know, for a society to say, well, we're only going to allow 2-level fusions, but only using these specific tools and these specific, that's a kind of that's a move that the Obama administration would make. That's actually trying to limit medicine.
I think you're putting words in my mouth right now, and I actually kind of offensive based on what's been said today about Obamacare, that you compared my train of questions to the bureaucracy that lays within that. So what I would like to clarify is the degree to which this society is interested in supporting a particular procedure which is controversial for a series of indications that may be progressively less adequately addressed by the procedure that we're talking about. So, I mean, at what point are you willing to step in and say, this is no longer something I think is appropriate to be done minimally? At what point are you willing to say, no, this is kind of fair, this guy's doing the right thing?
But let me just say this to you as well, Evan. You see, no one knows where the technology is going to be a year from now, 2 years from now, 3 years from now.
I don't want to make any laws. I don't want to make any regulations. I just want to have a discussion about what you think is. And I totally agree. And you have to have these discussions as right now, so that I can see what your thoughts are.
Let me address. Invasive. And it is important you understand that. If you're saying deformity, you're completely outside the scope of what we would define as minimally invasive, because those kind of surgeries will exceed either excessive blood loss or require tremendous amount of time to complete the operation and do not fit the outpatient setting. But it has nothing to do per se with whether it's minimally invasive or not. It's just that we have already set important guideposts to make sure that the sort of questions you are asking is a non-issue, in fact.
He's playing the devil's advocate, right?
Well, yeah, and again, I've seen people do single-level fusions in the setting of a complex deformity. And I don't, you know, whether or not it was appropriate is not the question. It's, you know, like, what are you trying to do? How does it fit in with the big picture? I mean, if you can go in and do a fusion with minimal blood loss using percutaneous techniques, but it's to address a complex deformity that addresses the technology question that was brought up before, maybe that's something we can do. And that's something that you've got to think about in the future. Sure,
later,
but now,
later in the future.
Yeah, but right now, I mean, like...
Right now, the level of technology warrants that we limit it to less than 12 hours, less than 150 cc blood loss, and using the guidance of fluoroscopic approaches to make sure that the dissection involved is minimal. If the deformity obviously dictates that the dissection is going to be more than that, then it probably would not fit into our definition. So we've already addressed these questions. And how the technology takes us, we are open. We are open to neurosurgeons, orthopedic surgeons, physiatrists, interventional pain with the skill set and the technology to take us where it's going to take us.
So at this point in time, if anybody were to perform a fusion that followed the minimally invasive guidelines that you set, that person would be justified as long as there was a reasonable indication and they had appropriate training.
Absolutely.
Period. Okay. However it was performed, wherever, what level, it's all the same, appropriate.
Was that personal? Yes.
Oh, you had to put that in there.
Answer to your question is a yes, yes, and yes.
Okay.
Yeah.
So, and Gabe, Steve, we have the technology. Instead of showing what you're doing by diagrams, show it live. Then I'll be a believer. Show me what you do live.
Yeah, but you know what was interesting, Tony, in the early stages of this? I distinctly remember Tony with his presentation showing videos of other surgeons. And when you see the nerve root, you see the disc herniation, you see the big hunted disc come out, everybody always goes, oh. And you see the nerves decompress. And then you get the surgeons in the other room talking, saying, that's dangerous, you can't do it, you know. So seeing and believing, yes and no.
One cowboy in Arizona.
That's right. Amen to that.
So Gabe, show me a diagram.
I'm gonna make sure I check it out.
So we have heard from physicians, we have heard from lawyers, we have a few pharmaceutical reps here. I guess I'm the only healthcare businessman today. You know, by the way, when you doctors fight hospitals versus surgical centers versus, you know, private practice, you know, I'm the one who is counting the green, you know. So basically, so I'll talk about my experience and the synergy and where the business is leading to. I have, so my name is Sam Rahat. And it's ASC Med Solutions is my company. We own surgical centers, practices. We go, you know, we have businesses in 3 states, New York, New Jersey, and Connecticut. And, you know, I stay in New Jersey most of the time because I'm pretty hands-on running my surgical centers. I have been in this industry for almost 2 decades. I have been a hospital administrator. I worked in a couple of hospitals between New York and New Jersey, mostly in business. And also, I have worked for health insurance companies. I used to be the claims director of a Medicare Plus Choice HMO. So I know very well how they stop your payments. And that's why I do well on this side, because I know how to get paid. And, you know, because if you work 16, 17 hours, you know, standing, I mean, I literally see hundreds of procedures every month. You know, I go in, as a matter of fact. I'm not one of those management guys you don't see in a facility. I'm inside the facility. I walk around. I make sure everything is going smoothly. And I see these procedures. I have seen tons of them over the years. And I'm a big advocate of minimally invasive spine procedures, especially if they're done in an ambulatory surgical center. I don't know what technique you use, if you use Joymax or Wolf or something else, you know, or if you call yourself surgeons or spinologists, you know, it's, you know, but I really think it's, you know, it's a very safe procedure. I have, we do about, I would say, in one of our centers, almost 400, I would say 350 procedures a month. out of 350, at least 50 or so would be minimally invasive spine procedure. That includes discectomies, fusions, and other spinal procedures. So, and as since you all have spoken before me, and I'm the only non-physician, attached to healthcare, I would say that over the years, I have seen many of these procedures done either on our center or centers that I'm affiliated to or that I know. I have not really heard of any issues like patient bleeding to death or, things like that. If after the procedure when they may have complications, I would say less than 10% or maybe 5% of the times we transfer the patients to a hospital, to a nearby hospital, and that's exactly why we have this agreement with the hospital, the transfer agreement, that in case of emergency, we can actually send the patient to a nearby hospital. But it never got to a situation where the patient is, that's why we get the medical clearance before the procedure. We have to make sure that we do the blood work, we have a medical doctor check out the patients and all that so that we don't have to go through those things. And as long as the incision is small, you are physicians, I'm not going to talk about medicine and surgery, but it's, to me and my experience, I'm only going to talk about my experience. I really have not seen much complications in an ambulatory setting. Hospitals, and I was in a meeting actually this year, I believe beginning of this year. And I have had, in that meeting, we actually had the whole Department of Health. And I got a really interesting number from the Department of Health, that there were a few thousand infections reported. I believe it was 4,000 something. Only 28 or 29 out of a few thousands that were reported were from the ambulatory surgical centers. The rest of them are all from the hospitals. So there is a problem. If it's less than 1% infection rate in the ambulatory surgical centers, I think it's good. It's really damn good, and everybody should consider the ambulatory surgical centers because it's patient safety is the most important thing that any physician or anybody should, think about. And, if you have an infection rate which is actually, 1% or less, I mean, that's real patient safety to me. And also, sometimes we see that in the hospitals, I'm not talking about the top-notch hospitals like Johns Hopkins or Columbia Presbyterian. I'm talking about your average hospitals or maybe community hospitals or, I visit a good number of hospitals every year. And every time I go, it really, I really get surprised by their care, by the technologies they're using, by the equipments that they have. I'm sure most of the surgeons here, have had hospital experience. I'm not saying anything against hospital. I'm talking about surgical centers, okay? So just don't get me wrong, and I know these, especially the doctors there, with all due respect, have you ever visited the sterilization room in a hospital yourself? If you haven't, I request you to go and see how it looks like. And then you would know what I'm talking about, because I have visited a good number of them. And then you go to any of the state-licensed, JACA-accredited surgical centers and see their sterilization room. Especially, I mean, you're most welcome to visit our center. We have two centers in Patterson, Accelerated Surgical Center and Barnett Surgical Center. Both are state licensed and JACA accredited. We have about 25,000 square feet, and do about almost 1,200 procedures a month. So then, as I said, the number one, consideration should be patient safety. And when we actually see those things, then you would know that, how, it would come to your mind that would I, if you would really consider ASC versus hospital. I'm not, I'm talking about minimally invasive procedures. And of course, what New Jersey PIP, the auto insurances did, I still don't get it. That you have to do a discectomy in a hospital and an inpatient basis. It really, I have, all the good, experienced physicians right in front of me. Seriously, how do we justify that? And we spoke about it. The problem is, I'll tell you what the problem is. Today, this is like to me, it's an historical event today, because we are talking about guidelines on minimally invasive procedures. We are talking about a lot of things. I'm not going to say setting up standards because I'm not going to get beaten up by an attorney, but guidelines. So it is an historical event today. And look how many interventional pain doctors are here. I can only see a couple, really. So, but they're all waiting to SASI to do something so that they can take advantage of it. But when it comes to real support, where are they? They're not here. They're busy making money. Everybody is, today is what, Saturday. Everybody is doing procedures today. They don't want to come out in to support the interventional pain physicians on a Saturday so that we can take this to the next level, really. Okay, but guess what? Once you are done with it, Dr. Richard Kaul gets his licenses back, where he, by definition, we all know in the state that it says physician and or surgeon, and he's really one of the best guys to do spine procedures. And I have heard it from many doctors. Good doctors, bad doctors, obnoxious doctors, great doctors. I know so many doctors, and you know what? All of them said one thing about Richard Kaul, that I don't know if he's trained in surgery or if he's trained in interventional pain or if he's trained in anesthesia or pain management, but one thing I'll tell you, this guy has God-gifted hands. I personally did not have the opportunity to see Dr. Richard Kaul on the table, but I have heard a lot of good things about him, besides the fact that, he's a monk, okay, also on the side. So what I'm saying is surgery is an art. You have to be a really good artist to do surgery. Although I'm not a doctor, but I do work with so many doctors, and in my lifetime I have worked with so many doctors. Yes, Dr. Kaul.
Can I just ask you a question?
Sure.
What do you think it is about the ambulatory surgical center model that that impacts or brings together a sound economic and clinical model?
First of all, cost efficiency. If you're doing this, by the way, I know many of you may or may not know, when they said that you cannot do this in minimally invasive procedures in a surgical center anymore, they said you have to do it in a hospital. Guess what? The hospitals do not have a fee schedule. So if the hospital is billing out $180,000 for a half-an-hour procedure, they're getting paid for it. Because it's, so basically it will be very cost effective for the patients, for the insurance companies, and for everybody, even for the physicians, because if you're coming to a surgical center, you're doing the case, you're in and out. If Dr. X is scheduled in my center with 3 procedures, he's done in about 4 to 5 hours. He can do 4 to 5 pain cases in an hour. And we run, if you have more than 10 pain cases booked, we would run 2 rooms for you. We'd give you, 3 separate, 3 sets of crews, So basically, it's we try to do everything in such a way that it is cost effective, and because it's less, risk involved, after effects, so it's post-op problems, so you actually save money in every way, because nowadays what the hospitals are trying to do is to book the patient, to keep them for a couple of days as inpatient, where really the patient, there is no need for the patient to stay in the hospital for a couple of days, and they're doing it. So it is absolutely, and also, on the other hand, because of the cuts and the fee schedules and all that, I'm sure that what you got paid 8 years ago or 5 years ago, you're not getting paid, probably 20 or 25% of it today. It's probably less than that. So now, you had all, you know what, I'm always for the physicians, because you go to school, you spend so many years preparing yourselves, then the residency programs and all that, and after spending years in training, you come out, and then all of a sudden you're making less than an IT guy. That's sad. So now, the ambulatory surgical setting is actually good in a way, because you can always invest, you can always buy in, and make sure that, and get involved in the operating process, have a vote, and make sure that that your patient that you're bringing in is getting the right care, because that patient, if you take that patient to the hospital, you have no pull. You cannot do anything about it. You just have to be in their mercy, that's all. Okay? So now, at least in an ambulatory surgical center, you can actually have a pull. You can dictate in a way. You can tell them, hey, you know what, Sam, I want my patient to be treated this way. Make sure you have 2 nurses for each patient, and make sure you have 1 anesthesiologist, 2 anesthesiologists doing the turnovers. Make sure that in the recovery room, you have 15 minutes, at least, you have an anesthesiologist in the post-op. Yes, I would do it at any time, because you know what, you're important to me. You're a physician who's doing cases, and patient care is very important. And at the same time, there are, a lot of investments involved, so we have to make sure that we do provide an excellent service, a 5-star service. Of course, the staff, you don't have to, the thing is, unions in the hospital, that's a major setback, okay? And it's very, very difficult when it comes to these things, moving the staff, doing the right things, So basically, this in the surgical settings, you have really good trained staff, and there is no, no unions to deal with and all that. So absolutely, it makes everybody's job much easier. I'm slightly moving on to a little bit different subject matter, because I'm praising the ambulatory surgical centers too much, so I might get hit big time with a couple of my fellow, doctors sitting in front of me. But I know that most of you actually would agree with me when it comes to ambulatory surgical centers. So now, out of curiosity, since I'm not a doctor, I really never paid attention to the Board of Medical Examiners, because I deal with the Department of Health most of the time. So out of curiosity, when Dr. Kaul got hit and all these things came on media and everything, I went through their training. I pulled out a list of the new Board of Medical Examiners in the state of New Jersey, just to find out that, what's their background, really, to decide on something like this. It's sad that, the whole group has mostly internists. The president is a podiatrist and a DO. the only closest person who's an orthopedic surgeon, and I don't think he has ever touched a spine, really, who graduated in 1963 from a medical college in the East. And back then, I believe orthopedic surgery was all about casting, not putting nuts and bolts and screws. You know, so basically I'm very surprised. I'm very surprised that, and by the way, the board can take my license away all day long because this is the only license I have, New York State driver's license. You know, so that's why I can speak. But it's really sad. It's really sad that, you know, they're deciding on something which needs, you know, much more understanding and experience, and they should actually see how these procedures are done, and I hope that, you know, if in future, you know, near future, so to speak, that they make some changes, because, you know, honestly, this robot that's sitting in Hackensack Hospital, who is that robot licensed by? Can anybody tell me? Is that Board of Medical Examiners or is the Department of Health? Is anybody has any answer? Doc, can you tell me? Because all I see is the doctor sitting and playing with a couple of joysticks, which my son can do probably a better job, my 9-year-old, you know, doing the video games. So basically, times are changing. This is the time of robotic surgery, okay? So now, if a 1963 model, you know, Ford Mustang is deciding on how we're going to make the, you know, how to control the flying cars. It's not, you know, appropriate. I mean, it's how can they relate to the new technology? They have no clue. So now, if a robot can do surgery, I don't see why Dr. Jasper can do, or Dr. Richard Kaul can do, or any of the interventional pain doctors here can't do surgery, because actually there is a human touch to it. And I think at times it is important. And as I said, I'm not, you know, we're not talking about incisions that are 1 foot long, you know. These are minimally invasive procedures. 1 centimeter, 2 centimeters, max probably what, 3? Something like that. So, you know, so times have changed. I think it's all, you know, it's time that we all, including the state, the federal government, the physicians, most importantly, the physicians need to support the other physicians, help each other out. They're always, you know, there's some kind of beef with each other. I don't understand that. You have to be united. The end of the day, what I'm saying is the physicians have to be united, period. Then only you can make a change. You cannot make a change because, oh, I didn't go because Dr. Jasper is here. I don't like Dr. Jasper. I've heard that, by the way. So what I'm saying is, I'm just, no, I'm just kidding. Don't worry, I'm just kidding. What I'm saying is, that's how it is. That's how it is, because they're like, oh, Dr. Kaul is there. I don't think I'm going to go. You know. So end of the day, we'll all have to be united. The physicians have to be united. And anything that I can do to do that, I will do, because I'm very well connected with most of the doctors in the state, especially in the state of New Jersey. And definitely, you know, I'll try to help SASI to put the physicians together, the doctors together. I wish all the best, and I hope SASI takes this to the next level. I hope all the physicians, all the minimally invasive spine doctors, the spine surgeons, you know, are recognized, and all the best. Thank you.
Thank you so much, Sam.
Oh, yes, Doctor. We're all interested. insurance companies say, you're not a surgeon, so you don't get paid like a surgeon. Do you have that problem in New Jersey?
We don't.
Number two.
Because, as I said, in Jersey, we do mostly out-of-network care, and we do PIP, we do workers' comp, and really, if you have a certificate from, saying that you are trained in minimally invasive spine procedure, that's good enough. I mean, I go through this every day, but the moment, it depends on who's handling it. If you have somebody like me handling this, I'll get it done. If you have a $10 front office girl who joined you yesterday, handle this, you're not gonna get it done.
We're out of network also, and Kaul, United Healthcare say, out of network we pay Medicare rates.
You are absolutely right. You're absolutely right.
Let me answer that.
Yes.
I'm in Indianapolis, and all the doctors are in network with the exception of you. So if you're not in network, you can't see patients. Right. In New Jersey, New York, it's just the opposite.
Correct.
How do the major insurance companies come up with usual and customary? For instance, my contract with Ambulance now has all carriers in Indianapolis. We're Medicare-based, fee schedule. Okay. Now, if I was at a network and lived in New Jersey, sometimes the variance is incredible. $1,200 for surgery in Indianapolis versus $12,000 to $25,000 for the same procedure. $300 for an interventional procedure versus $3,000 to $5,000.
Right.
How do they get away with doing that? And how is that defined? I mean, because usual customer seems to vary from state to state. There's no rhyme or reason.
Absolutely, because in the state of New Jersey and also in New York, this out-of-network business has been going on for quite a while, okay? So slowly, the user and customary rates have increased. So it got to a level that because it does not say legally that if I want to say I have a cell phone store and you have a cell phone store too, you are selling a cell phone for $50 and I'm saying it's $500. Who's gonna tell me I can't sell my cell phone for $500? Same thing. If you think your care costs $5,000 versus somebody else's $500, you are free to do that. Now, New Jersey, New York may have something different. So they average it out in the state and come up with the user and customary number. What I do, we calculate based on overhead, how much space we have, what is our overhead, staff, these, that, yada, yada, yada. But what happens is, I usually, we increase our numbers because we know they're gonna come to a settlement. And everybody who's in this, in the business of out-of-network, they all do the same thing. So we settle most of the cases. We settle at 60%, 70%, whatever. And even that 60 or 70% is way better than getting paid in network, because in network you become literally a slave of the insurance companies, and they will dictate everything. No, you're absolutely right. I'll tell you. I'll give you a perfect example. I had this case, and they had Medicare rates imposed on out-of-network people. Okay, out-of-network, it says out-of-network, PPO, yada, 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 United Healthcare, something, Cigna, whatever. So we're like, okay, everything is good. Yes, they have out-of-network coverage. We verified and everything. All of a sudden, towards the end, we find out. So they call from my verification department, call 80% coverage. Okay, 80% of what? 80% of Medicare. We didn't know that. That's what they're coming up with. Tricky. We'll cover 80%. So of course, being in the business for such a long time, we're thinking it's 80% of usual customer rate. No, it's 80% of Medicare rates. Fine. How much is it? For endoscopic discectomy, they're going to pay $800. Disposal, the equipment's involved, they cost way more than that. For a fusion, if you do a fusion, your only implants can run up to $27,000, $30,000. If they're paying you $4,000 for a fusion, and they're saying they're not going to get you, reimburse you for the implants, how can you do it? How can you do it? It's impossible. So that's why it's very important. I mean, you just have to be
understand how to play their game. That's what it is. Because they're making money. Their boys are making $20–30 million salary for playing golf every day. And here we are. The patients are suffering every day because good doctors are not looking at the patients. They have to go to some, some hospital where they're not going to get the proper care. And that's what it is.
Thanks so much, Sam. This is very entertaining. To balance things out, we've invited another business person to discuss finances.
Well, before I get into my segment, let me just say I'm, as a layperson, utterly impressed with both the passion and the intelligence in this room. And I just encourage the doctors to keep doing what you're doing. I could say it's a timely thing. I actually relate to every conversation in this room today. I walked up here in a cane. I've got this bum right knee from my college football days, and I just completed a stem cell procedure. And as I was going through the procedure, 6 doctors were in the room watching the procedure, and they covered every continent in the world. See, the guy I went to is a renowned guru, probably who Dr. Young was 10, 15 years ago, teaching people for the first time. And these doctors stood there from every continent in the world, open-mouthed, because it was remarkable science to them what was going on, okay? And I think you guys are way ahead of that curve, okay? And I think we know that minimally invasive spine surgery is right. It does work. And again, I want to encourage all you in the room. I think it's great what we're doing here. And again, it's a very timely thing, and it really hit home for me today, okay? Let me just give you some quick little background on who I am. I'm on the board of SASI, and I'm sort of the financial guy, if you will. And my background is that I'm the senior partner and principal of a 500-person firm called Summit Financial Resources. And what we do is basically work across 4 disciplines and the globe. We work with the treaties of every country, interstate, interprovincial, international, 4-discipline shop, law, taxes, insurance, investments, and we become a total advisor to our clients, okay? One of the functions I'll perform on the board is at last night's board meeting, we decided that we will be sending our members a quarterly newsletter, okay? And that newsletter will help the members with other than just medical articles, which certainly medical articles will be in there. There'll be some advice in the financial side, legal side, practice management side, okay? Again, trying to give the members some value, okay? What I'd like to talk about today is just a couple of areas that I think will write articles on that will help doctors run their lives, if you will. Now, you doctors are busy between career and family, and you can't be a financial guru. You can't do it all. You can't be on top of the law and finances and accounting, okay? So there's where disseminating information is going to be very helpful. And we have a program that is specifically tailored for medical professionals, okay? I don't suppose anybody in the room is savvy to section 1563 F5 of the code, okay? Because I told you about it last night. There is a little-known tax code, okay, that allows medical professionals to recapture some of the tax write-offs you don't get, okay? I should mention that medical professionals is a profession that has less tax write-offs than other professions, okay? You're at a loss. In fact, lawyers are second, okay? And what this tax code allows you to do is to get around rules, okay, where you can form alternate corporations for other things that you do and get more expense write-offs, funnel more money into pensions and qualified plans and tax-deferred plans, okay? The way we do this is we carve out some of the functions that you do as professionals. The first area I'll touch on is, and to give you an example of this, none of you doctors go to a cocktail party when someone says, "What do you do?" You don't say, "I don't have a business card, I'm not very good anyway, so don't call me." No, what do? I can see the passion in the room. You market yourselves. You say, "I'm a minimally invasive spine surgeon." And you talk about what you do, and you probably get into a long conversation that lasts more than one martini. What you're doing is you're marketing yourself. Well, doctors don't have a tax write-off, a good tax write-off for marketing, or for the amount of marketing they do. So by integrating this plan, we call it an integrated business plan with income splitting. We take out the marketing function from what you do as professionals, doctors and lawyers. We then have more expense write-offs. We can funnel much more money into qualified plans. And we can get around the rules that say you have to give those pension plans to all employees. You literally could form a marketing company. Now, we have to do a business plan. It has to be legitimate. This is not a tax scam, okay? It has to be a marketing entity that handles your marketing, okay? Which is easy to do. There's a fellow in the room that talked about managing the internet. Okay, that's part of your marketing, okay? We carve that out as a separate company, okay? And that's part of the income splitting program, okay? As doctors, you have collectibles. The way we handle debt, accounts receivable, okay? We can form a separate company for the handling of your debt. Again, we can get around the rules. You don't have to have the same amount of employees and give them all benefits in these separate companies. The tax code allows us to do this. This is strictly in accordance with the tax code. So these are some programs that we implement. And then on top of that, you can do things like HSAs, HRAs. We could do classic pension plans if you're motivated to get money socked away for retirement. And then we adjust the bookkeeping system, okay? So what we will be doing through the newsletters is giving some practice management advice, financial advice to the members, okay? The other area, just quickly, I want to talk about is in order to get to that place where you no longer have to do these surgeries, as you get older, you want to retire and sit on the beach, you're going to need to get there by being tax efficient and by investing your money wisely, okay? So let's talk quickly about a tax efficiency idea. The world of annuities has reinvented itself, and probably I went about a 15-year span in my career where I hadn't used a tax-deferred annuity one time for one client. Why? 15% capital gains tax. The old annuities had high internal fees, high costs, not a robust lineup of funds, okay? But this is a new day, and the annuity world has in fact reinvented itself. There's two types of products out there that are very interesting, okay? One is effective as of January 1st of this year, and that is a no-load, tax-deferred variable annuity. There's no load going in. Again, the old annuities had 2, 3, 4, even 5% hitting costs up front. These are no load. It's about 400 funds to choose from, okay? You could trade those funds. This is not a fixed annuity. You're buying mutual funds, okay? You do not have to annuitize this on the back end, okay? The money is liquid to you on the back end. So you amass the money, you take it out as you wish. If you pass away, it goes to your heirs, okay? So again, even though they got tax-deferred status, we were shocked the annuity industry got annuity status on this, because really all it is a no-load, tax-deferred shell by which to invest your money. Now, the other option is to invest in stocks and mutual funds and pay taxes all those years. So all this really is simply, again, is a tax-deferred shell. Okay? There's another genre of product through the annuity industry that gives you guarantees. Okay? And those products, you will pick mutual funds, you'll have a guaranteed column, and you'll have a mutual fund column. The mutual fund column is the actual return you do in the funds. The guaranteed column is an absolute guarantee that they give you. Let's call it, well, most companies, 6%. Okay? You're allowed to make trades. The annuity will accrue each year. You will cut out all of the down and lackluster years of the market. So you're going to accrue at 6% or better. On the back end, you have to withdraw the money out in an annuity stream on the second product. You have to draw it out in an income stream. Okay? That's the catch. And by the way, that annuity stream can never go down no matter how poorly your investments do. The day you go into what's called withdrawal mode, okay? Let's say 100,000 grew to 200,000, and you're drawing down from 200,000. From that day on, no matter how poorly your investments do, you'll get a set return. It's usually 5 or 6% on the way out for the longer of 2 lives. What you're doing with this product is creating your own pension. And one of the problems with retirement planning today is this generation, we don't have pensions. Okay? And that's what this product really does. It creates your own private pension that'll continue to the longer of 2 lives without downside risk. You have some expenses. There's about a point in there of expenses to give you the guarantees. But this is not something you do with all of your money. It's something you consider doing with some of your money. Okay? And by the way, the integrated business plan with the income splitting, that's also not an all or nothing type of strategy. There are pieces of that you can do to reduce your taxes. Now, let me give you some magnitude on that. The integrated plan with the income splitting, if you do the whole plan, we're talking about the potential for tax savings of somewhere between $100,000 to $300,000 on every $1 million of income. We're talking about some very real numbers. This is not a small little tax break. Okay, we're talking about a very large tax break. Okay? And yes, it's been through the audit process. It's been audit tested and held up every time. I just wanted to give some examples of some ideas that we would throw out in the newsletter, which again, I think the members would find helpful because again, doctors are very busy between career and family. And if you can get to the point information that is specific to doctors and is advice that's across 4 disciplines, once again, law, tax, insurance, investments, I think that would be very helpful to the members. Any questions?
Is there any early withdrawal penalty on the low band?
You could take out lump sum at 59.5 and income at 55. And if you take it out too soon, there's a 10% penalty on the growth only. Okay. But lump sum at 59.5.
What's the name of that tax?
It's called a tax-deferred, no-load variable annuity. And when I say no load, let me just give you a quick explanation on that. In the old days, again, there'd be like a 3 to 5% charge up front. This is 0 up front. So you're accessing the mutual funds. Okay, the brokerage community is cut out. There's no commission paid to the brokerage community. You're accessing the mutual funds at what's called the NAV cost, which means no other commissions or loads or costs in those funds. It's the pure cost of the fund. Your total admin cost to have this tax-deferred shell is $240 a year. That's it. So everybody's working lean on this. The mutual funds are not marking up their expenses. They're giving you the raw expense on the fund. Okay, the vendor gets $240 a year, and they make some kickback from the mutual funds, but that doesn't cost you any money. And the brokerage community is completely cut out. So it's a very lean, low-cost product. Any other questions?
I'm not a financial person, but the 4% or so on logarithmic growth by having no load is significant over like 20
Oh, yeah,
years.
yeah, that's right. If you cut out a 4% hidden cost up front, and you let that money ramp up for 10 or 20 years, just not paying the load up front makes a big difference alone. Right.
Thank you.
Okay, thanks.
Well, the whole point of this discussion is to show that SASI is about value. SASI is about science, SASI is about collectiveness, and SASI is about growing the body of minimally invasive spine surgery, not only just for the patient, but for the communities that we work in and also for our physician members. Thank you.
As with any new organization, their challenge is going to be credibility. And so there are a lot of players already in this marketplace. So if I was in their shoes, I'd reach out to International Spine Intervention Society, Society for Minimally Invasive Spine Surgery, ASSR, NAS. It's really difficult to get a foothold when there are so many other groups out there in this space. So if they really want to develop good standards, they've got to do it the right way. If they can do it in a collaborative way with other organizations, that's going to help them a lot. Well, I would agree that their initial focus is on target, and there is a gap, that there needs to be some kind of guidelines developed for interventional spine treatment, minimally invasive spine. So they have an opportunity to really do something right. But whatever they do, it's got to be based on evidence. So if they write clinical guidelines, appropriate use documents, they've got to build the credibility over the organization through the evidence base. Well, we have minimally invasive spine as part of our organization. We have a section on minimally invasive spine surgery. Raj Ramprasad is the chair of that. He's from Canada. We're actively involved in helping develop educational content for minimally invasive courses. There's one in France in May we're going to be involved in. We're going to send 3 speakers to it. So it's definitely on our radar screen. We have educational courses at the North American Spine Society annual meeting. On MIS, we have pre-courses. So it's part of the fabric of the society. And as the reimbursement system evolves, I think that there's going to be a greater emphasis on minimally invasive approaches. So we view this as a growth area for NAS in the future as well. To a degree, you know, it's a crowded field. Spine is a crowded field. Neurosurgery, orthopedic surgery, physiatry, interventional pain management, interventional radiology, they're all vying for attention of the society. We've got 8,200 members. We've got 23 different disciplines, including nurse practitioners, physical therapists. And so there's a lot of competition to get on the program at the annual meeting. So the way that people get attention is coming at it from an evidence base. And as long as they stay focused on that, don't get distracted by any of the other issues, start there, they can build an effective organization.
I think the lack. First of all, let me say I think the lack of any standards regarding education in the field of minimally invasive spine surgery was clear. So I think there were no lines that are defined anywhere. The understanding of guidelines that have been put out by various societies, one of them being the North American Spine Society, provides some illumination, I think, on the field, which is a good thing. And I think that the different specialities that have been involved and are becoming more involved in the field of minimally invasive spine surgery, I think that each of them has their own guidelines or an understanding of where those guidelines should be. Yesterday when we had dinner in advance of this meeting, we were talking about how do we establish standards so that everyone understands, so that we have something that that people know in black and white, that this is what you need, and if you don't have it, this is how you can obtain it. And I think this is an area of minimally invasive spine, is the fact that these technologies and these techniques are relatively recent. Means that the different specialities, the interventional pain physicians, the interventional radiologists, the neurosurgeons, and the orthopedic surgeons have to come together. And this is, one of the missions that SASI has, is to bring these different experts together to establish a standard. And I think that from the meeting today, I think that I was very encouraged. And I think it was a very constructive and positive meeting. And I thought it was a great show from NAS that they sent a representative to the meeting. And I did like what Eric said, that we have resources, that we can work together. I mean, that was what he was saying. He didn't directly say that, but he said that we can come together and we can start a collaboration and try and put into place a standard. Yeah, that's a very good question, and I've given significant consideration to this. And the acquisition of the skills to perform these procedures. You see, the interventional radiologists and the interventional pain physicians are, in my opinion, well trained in the use of fluoroscopic guidance and interpretation. The majority of them, however, are not well trained in how to use instruments to remove pieces of ligament, pieces of bone, and to maybe traverse parts of the neural canal. The neurosurgeons and the orthopedic surgeons, and the majority of them, again in my opinion, are not particularly well trained in the use of fluoroscopic guidance and interpretation. And so I think in terms of bridging the gap, it's a bridge that is, people think, well, it would only be the neurosurgeons or the orthopedic surgeons who would be bringing up, kind of giving a helping hand to the interventional radiologists and the interventional pain physicians. But actually, it's a two-way thing. So it's about the guys who have had training and have experience in fluoroscopy, about them bringing their experience and their skills into this arena, and about and the neurosurgeons and the orthopedic surgeons bringing their experience and their skills, so that we start to exchange that information, and that both sides can grow together. Because spine surgery of the future, fluoroscopic guidance and imaging techniques are going to play an increasing role in spine care. But similarly, interventional radiologists and interventional pain physicians are going to have to also know how to handle surgical instruments, how to dissect through various parts of the back, how to identify nerve roots, and how to remove pieces of bone safely. I think that definitely in the cadaver lab, that's the starting point. That's where for the interventional radiologists and the interventional pain community, they're going to have to learn how to handle pituitaries, kerosins, the basic instruments required for spinal decompression. The moving into the life situation absolutely can happen at a facility such as Dr. Young's in Arizona, but also we have simulation models now as well, where doctors can train. And I think that where we have models that will bleed and where there'll be nerves, so I think training will happen in those scenarios as well. I think it is a legitimate concern. I think it is. I think that, but I would also say that with any type of procedure, whether it's just placing a needle, a probe, whether it's putting in a small tubular retractor, the same types of complications can occur. And, the incidence of those complications, I would agree, tend to go up with the invasiveness of the procedure. And so I do accept that the majority of doctors, when they express their concerns, there's a legitimacy to it. I would also say that there's also an aspect of it that's self-interested. But I think in terms of making these procedures safer and more effective for patients, I understand the need for collaboration. I think what differentiates SASI from the other professional societies and organizations is that it's developing a credentialing and training program that is going to result in the issuing of a certificate, a credential, but also a society that's going to stand by its members and in 4 arenas. And this is part of the mission. This is something that we all discussed significantly early on, was to represent physicians from our speciality in an educational forum, a clinical forum, a legal forum, and in a business forum. And I think within the United States, because of some of the sensitivities of the legal system, it's important that doctors who belong to the society feel that when they enter a courtroom or if they enter a medical licensing board room, that they have support in those forums. And so what I think and what does differentiate SASI is the fact that there's going to be an actual training and credentialing program in place, which the other spine societies at the moment don't have. Yes, and we discussed this last night. The first hands-on cadaver training course is going to be in May of 2014, and there are going to be 3, 6, 9, and 12-month modules of training. So we're hoping to have, well, by the end of 2014, we're hoping to have 2 SASI fellows credentialed. SASI, it's a 501c6 charity, so we'll be looking for donations, but also a number of the device manufacturers who themselves have been repositioning their marketing strategies towards percutaneous and MIS technologies, and also understanding that the doctors, the interventional pain community and the interventional radiology community provide a significant opportunity for them. So we're going to be looking to those companies to contribute monies to these training programs. when SASI was first conceptualized, there were discussions at that point about coming up with a standard and a credential that would be recognized around the world, and it would a SASI credential, it would communicate a level of training and a level of competency that would be recognized globally. Now, the global spine market and the increased requirements for spine care, that's something that requires training and education of physicians in different parts of the world. And SASI's role in that, and again, and that's also because the board members of SASI, I mean, these are people who have, on average, more than 10 years of experience in this field, have a significant international network of doctors that they've worked with and they know. So the development of, I suppose, a global healthcare strategy, particularly in spine, ties into improving education and training of local physicians, but it also ties into the way that technology and the relative cost of these technologies is coming down. So the cost of screws, the cost of interbody devices, that's changing. So, I mean, and also other parts of the world are becoming more industrialized. Other parts of the world, particularly Asia and even sub-Saharan Africa, there's a significant amount of, well, there's been a significant growth in their economies over the last few years. And actually, sub-Saharan Africa, in terms of which part of the world is going to see the most significant economic growth, it's that part of the world. And of course, with that come the problems and the afflictions of the spinal column. And so, you know, I see, and I think there is going to be an increased need and demand for, you know, high quality, cost effective spine care. Well, there is a model actually that we're trying to emulate, and if I can just answer that by saying medicine has always been, in my opinion, a little bit parochial. And the example I used the other day when I was talking to someone about the SASI credential, I said it's the same model that, for example, someone who has a Harvard MBA. You know, a Harvard MBA is a Harvard MBA. I mean, it's recognized globally. And I think that you're right. There is no model that exists that has that global recognition. But that's what we want to make a SASI credentialed physician become. Yeah, I agree. That, I mean, there are significant challenges. The overriding challenge, which kind of goes across all of these 4 elements of the mission, is just establishing credibility, because we, you know, although the idea has been around for a few years and we've been talking, we really are a new society, and so we're going to have to establish credibility with the other societies. We're going to have to establish credibility with the licensing medical boards in each state, and that's going to take time. It's going to take money, and it's going to take a continued commitment from the board members of SASI. We're going to have to significantly grow our membership, but we're going to be growing our membership both within the United States and overseas. So, you know, I know that at the moment, NAS, which is the largest spine society in the world, it has a membership of 8,000. I mean, NAS has been around for 25 years. So it's, we're not being unrealistic in our goals. I mean, we're hoping to have, by the end of 2014, 300 members signed up. So, and we feel that by you know, creating that kind of a membership base, that by the end of 2014, we will have moved somewhat down that road. Now, the easiest thing within the 4 elements of the mission, I think that we're going to be able to use the educational component. The clinical, the business, and the legal are going to take longer. But I think that the educational component, because by the end of 2014 we will have had, well, in May and then September, 2 of our hands-on training sessions, and then, as I said before, we're hoping to have at least 2 fellows that are going to be credentialed through SASI. Well, I think the other societies that have been around for 100 years, I mean, we're living in a very different time. I mean, you know, the digital age. I think that the use of communication technologies is going to expedite the rate at which the society grows in its reputation. I mean, the online digital teaching platforms, the virtual training platforms, I think are going to change the rate at which SASI's recognition is going to grow compared to a society that was set up 100 years ago. So I think that just by virtue of those facts, I think it's going to be a shorter time frame. One, I suppose generally, you know, as one's embarking on you know, a new venture in any arena and with a medical professional society, you know, we look back and see, you know, what mistakes previous societies made, try the societies that were successful and how they were successful, and we have looked at you know, very closely at the strategies that NAS employed over the last 25 years, and one of the things that I did like very much about what Eric said today when he was talking about the issue of education, and I thought it was a very magnanimous and fair comment that he made about the training courses and about the issue that they didn't restrict them to just neurosurgeons or orthopedic surgeons, and personally I was given the opportunity to benefit from that policy that NAS employed. So it was that approach that NAS took that allowed me to acquire some of these skills that I wouldn't otherwise have obtained. So I think that you know, as those comments from America about the really just using it and opening up NAS as an educational platform, I think that that is going to be one of the clear strategies that SASI is going to want to employ as well. And when we first came together and we were talking about the society and talking about membership, you know, the different doctors involved in SASI have different opinions as to who can and can't come in. So people take a position on that. But I think that and I suppose the open door policy, if you will, in a way, I think that policy, it worked very well for NAS, and I think it will work well for SASI.